Assalamu alaikum everyone. Can you guys hear me?
Yes.
Live, okay. All right, guys. For those of you who don't know me, my name is Mohammed Alfuwais. I'm a fifth year medical student. Inshallah, today I'll be giving you guys the first part of this crash course, which is going to be the cardiovascular section or the cardiology section. This is my first time giving you guys your batch and live session. Inshallah, the way I do this is I'll be teaching some parts at the same time. I'll be asking a lot of questions for you guys to answer, inshallah. So it'll be a very interactive session, inshallah. So let's begin. So the way I divided this is I'm going to be starting off with vascular, going over, for example, atherosclerosis and its complications and vascular tumors and so on and so forth. Then cardiac, which will cover everything in cardiology except for ECGs because of my colleague Leanne. So let's start inshallah now. So the first thing I'll be talking about is just the very basics of CVP, of vascular. So the arteries has three layers, as we all know, the intima, media, and adventitia. The media is the muscular portion. Now within the media, it has some elastic lamina that is very important, especially in bigger blood vessels. Why is this important? Because in certain pathologies, there will be disruption of this elastic lamina. Now, in bigger blood vessels, such as the aorta, it is very elastic. And this is also something very important for the control of blood pressure and the diastolic pressure, okay? So this is just the very basics. Now, pathologies can arise. Number one, most important thing is endothelial dysfunction. So in the lumen itself, anything can disrupt and disturb the lumen, the endothelium, and this can cause a set of pathologies, okay? Now, when you have disruption of the endothelium, this can cause, number one, atherosclerosis, number two, dissection. If it causes disruption endothelium and a tear into the intima between the intima and media, this is what we call a dissection, okay? So this is just the basics. The first thing that we'll talk about is atherosclerosis. What is atherosclerosis? It's basically a plaque that forms. Now, how does this plaque form? Number one step, as I mentioned, very important, is endothelial dysfunction, okay? Endothelial dysfunction. How does this endothelial dysfunction happen? Multiple reasons. Hypertension, hyperlipidemia, diabetes, many, many, many reasons, okay? And we'll talk about these risk factors. After you have the endothelial dysfunction, lipids, such as most importantly LDL, can go into the subendothelial space, okay? Now, LDL, once it goes into the subendothelial space, gets oxidized, okay? And now this gets uptaken by macrophages because oxidized LDL acts as a foreign body. So it gets uptaken by macrophages. Now, once it gets uptaken by macrophages, the macrophages won't be able to break it down, okay? So it will stay inside the macrophages, forming something that we call foam cells. Now, at this point, this process happens actually very early on in life. And this is what we call a fatty streak, when it's just foam cells, it's just lipids in the subendothelial space. Over time, these macrophages will keep on accumulating LDL, oxidized LDL, and it will rupture, causing inflammatory reactions, cytokines getting released, and this causes muscle cells to start forming a fibromuscular cap, okay? So this is what we'll call a fibrofatty plaque, which happens further on in life. The earliest manifestation, as I mentioned, is a fatty streak, and this is very important, okay? Later on, it will form a plaque, which is a lipid core plus a fibromuscular cap, okay? Now, this plaque can progress and cause pathologies later on, based on one major factor, which is the size of the fibromuscular cap. If the size is very small and very thin, this is what we call what type of plaque, if you guys know? Very small. Is it a stable or a vulnerable plaque? This is what we call a vulnerable plaque. okay? If the size of the cap is very small, okay? Now, what can this do? It can rupture and cause thrombosis, okay? So that is what we call a vulnerable plaque. A stable plaque is when the fibromuscular cap is very thick, okay? Now, the core of lipids, it won't rupture. This plaque will not rupture because the cap, it's very thick, okay? So it will just keep on building up over time, eventually will cause occlusion, all right? And we'll talk about this, inshallah, further on. Now, the first actual question I want to throw to you guys is, what are the modifiable and non-modifiable risk factors? Let's start from the modifiable risk factors. These are risk factors that the patient can change. Throw me some risk factors for modifiable. Excellent, good. So the modifiable risk factors, again, are risk factors that the patient can change, either control it by lifestyle modifications or by medications, okay? So you have diabetes, hypertension, dyslipidemia as the main three. There is one important habit that patients may have, which is what? Which is also a modifiable risk factor, smoking. Excellent, good. So these are the modifiable risk factors, okay? Factors that the patient can change. How about non-modifiable risk factors? They're factors that we cannot control. What are they? Genetics, sex, and age. Perfect. And family history. Now, age, obviously, it happens more in elderly. Okay, makes sense. It's a chronic disease, a chronic sequence of events that happens. How about sex? Which gender usually will develop atherosclerosis more? Males. Excellent. And then genetic diseases and family history of either strokes, myocardial infarction, heart attacks, or peripheral vascular disease. Okay. So now, what is this over here? What am I seeing here? What is the diagnosis? This is a very young patient, and he has no signs or symptoms of any disease. This is, as I mentioned, the very earliest sign of atherosclerosis, which is a fatty streak. Okay, you see this yellow bit over here? This is what we call a fatty streak. And as I said, what is this macrophage over here? This is a foam cell, okay? Macrophages that are filled with oxidized LDL, okay? So this is the earliest manifestation that can further lead to atherosclerosis plaque development, okay? This over here is an atheroma, which is basically the plaque itself. You can see this whole thing is the fibrofatty muscular core, cap, sorry. This is very thick. This is very good, and it's also obviously very bad, but it won't rupture. The thing about when it ruptures is it can cause thrombosis, which can occlude these blood vessels, and number two, can form an embolus. This embolus can go and clog distal blood vessels, okay? For example, in the heart, in the lower legs, and so on, okay? And this is the core, which is basically composed of lipids, all right? And this is just more of a microscopic appearance of it. You can see basically calcifications occurring, which are all these darker spots, okay? Now, this line over here is basically showing you the internal, the elastic lamina. The most important thing to remember about this is it causes disruption of it, so it can propose or it can lead to other complications such as aneurysms, okay? That's the important part about why the stain is here, okay? As I mentioned, this cap, if it's very thin, can rupture. And this is what we call a vulnerable plaque. And it can cause thrombosis over here or distal embolization, okay? Why is that so? Is because the lipid core, once it's exposed to the blood vessels, you have activation of platelets, aggregation of the platelets, and then you'd have the coagulation cascade that occurs. Here, on the other hand, the fibromuscular cap is very thick. Again, it won't cause this rupture and it won't cause this thrombosis. However, it will keep growing until it occludes the majority of the blood vessel, causing symptoms. All right. Same thing over here, as I mentioned. Here it's ruptured. Clearly, you can see it ruptured and cause a thrombus to form, and it causes the symptoms. All right. Now, one basically pathology that can happen to blood vessels other than atherosclerosis is something called arteriolosclerosis, which happens in medium-sized blood vessels or smaller blood vessels. Now, there are two entities of arteriosclerosis. What is this first one? A. Excellent. This is what we call hyaline arteriolosclerosis. Perfect. It's basically where it causes thickening of the walls with hyaline pink material. Okay. Now, there's two pathologies that can lead to hyaline arteriosclerosis, or two diseases. What are these two diseases? Excellent. Diabetes and benign hypertension. Okay, perfect. This is very important to remember. Diabetes and benign hypertension. This, on the other hand, is what form of arteriolosclerosis? Hyperplastic, and it's often described as onion skin appearance. Okay, this happens with what pathology usually? Malignant hypertension, which is basically blood pressure above 180 over 120. Okay, very high blood pressure. Okay, this causes, we are in the kidney right now in this image. This is the glomerulus. This causes renal failure. Okay, so these are the two entities. Remember, benign hypertension, diabetes can lead to hyaline. Malignant hypertension causes hyperplastic. Remember these two diseases. Okay. Now, what is this first image over here? What is this? Good. Monkberg, good. Monkberg medial sclerosis, perfect. Now, Monkberg medial sclerosis happens in young patients or elderly, usually. Elderly being above 50. Elderly, excellent. And it's basically where you have calcifications, which is all of these darker spots over here. That happens in the tunica media, hence medial sclerosis, okay? And the sclerosis just means calcification. This is usually found incidentally on autopsy. It has no clinical relevance, does nothing, okay? It's just important for your OSPE to remember this image and your MCQ, okay? You might get it, that's the answer, all right? Just memorize this image. On the other hand, what is this disease on the other side? Let's just say it's a young patient who underwent stenting. Excellent, good. Fibromuscular intimal hyperplasia, which is basically thickening of all the layers, usually more likely the intima that's being thickened, hence the name intimal hyperplasia, that becomes very thick. Now, when this happens, this does cause symptoms. This is actually very important because it can cause stenosis of the blood vessel, okay? Now, this usually happens, the main risk factor is any procedures that happens in the blood vessels. Usually it's a stent procedure that causes a reaction, which is the intimal hyperplasia, okay? And this is clinically relevant. The other procedure that can form this is, for example, called angioplasties, where they basically dilate the blood vessels and they fix basically if there's a plaque or something, they fix it. And this causes the irritation and the reaction, okay? Remember these two pictures very, very well. Now, one of the modifiable risk factors that you guys mentioned was hyperlipidemia, okay? Now, hyperlipidemia can have two main causes. Number one is the familial genetic causes, and we'll talk about all of them. The number two is usually with lifestyle, okay? Horrible lifestyle, the patient maybe is obese, has other comorbidities such as hypertension and diabetes, they will most likely develop hyperlipidemia because of their lifestyle. The other entity, as I said, is familial. To understand familial, let's go over just briefly the lipid pathway. So let's start from the GI. You absorb lipids through obviously first myocells, then chylomicrons. Chylomicrons are the lipoproteins that will take it from the GI, all the lipids from the GI to the liver, okay? So what do chylomicrons have in terms of apolipoproteins? A2, B48, C2, and E. Just remember these, most important ones. Now, which of these activates lipoprotein lipase? Do you guys know? All right, from these, the one that activates lipoprotein lipase is C2. Okay, this activates lipoprotein lipase. So what happens is this chylomicron in the blood vessel, you'll get lipoprotein lipase because of the C2. And it breaks down all the lipids inside the chylomicron, and it turns this chylomicron into a chylomicron remnant, which only has 48 in E. Okay. Now, in the liver, it received all these lipids. Okay, the triglycerides, the cholesterol. From the liver, if the body needs more fat, okay, for energy, it will produce VLDL. Okay. Now, this VLDL will go to the tissues, go to the bloodstream, and through lipoprotein lipase, again, it has C2 right here, it will be converted to LDL. This LDL will go to the peripheral tissues and deposit the lipids there. This LDL is the worst part of the entire lipid cycle, as we know from first year. Now, something that's very good is HDL. HDL does something that's called reverse cholesterol transport, where it takes the lipids from the tissues back to the liver. Okay, how does it do this? Two important enzymes. The most important one is LCAT. LCAT just means lecithin cholesterol acyl transferase. Okay, that's basically the enzyme. This one takes the cholesterol and deposits it into HDL. Okay, this is what actually takes the cholesterol. Now, HDL through CETP, which is cholesterol ester transfer protein, will transfer this cholesterol back to the liver and to, for example, to produce more VLDL and then LDL. So if you have more LCAT, that produces more HDL cholesterol, which is actually very good. Okay, we want more HDL. If you have low LCAT, this produces less HDL cholesterol, which means more cholesterol will be deposited in cells and tissues. Okay. On the opposite side, CETP, more CETP is worse because we're going to bring back the cholesterol to produce more LDL at the end. So you want less CETP, okay? Basically to produce a positive effect. So this is basically the pathway. Now, this is basically another more detailed diagram of it and basically explains it better than this small one from your slides. But to remember just how we inhibit a lot of these like lipid pathways is in the level of GI, we either inhibit bile to basically decrease the amount of reabsorption of or absorption of lipids into the walls and into the bloodstream. Because bile, you need it for the absorption. So you decrease the amount of bile, and I'll explain this more in the next slides. And basically this will cause more cholesterol to being used and so on. Or you basically inhibit cholesterol absorption through this one drug, and I'll explain this later. Other than that, you want to increase lipoprotein lipase because this will break down a lot of the lipids from the bloodstream. And you do this by activating something called PPAR alpha. Or you inhibit endogenous secretion or synthesis of cholesterol through this, or through niacin and the LDL receptor degradation. I'll explain this again in detail in the next slides. Now, now the next thing that we need to talk about is going to be familial hyperlipidemia, which is 5 diseases or 6. Okay, let's talk about them one by one. The first form of hyperlipoproteinemias or hyperlipidemia is type 1. Type 1 is because of a defect that happens because of lipoprotein lipase and C2. Okay, this affects mainly chylomicrons. Now, chylomicrons will take lipids from the GI to the liver. Okay, that's its first step. This chylomicrons has a lot of triglycerides. Okay, because it's just coming from the GI. You just ate a bunch of triglycerides, it's taking it from the GI. Because of the chylomicron amount of lipids it has, it makes the blood very turbid. Okay, very milky-like appearance, which is a very important sign of type 1 hyperlipidemia. Okay, the pathology is an ApoC2 or lipoprotein lipase causes elevation of chylomicrons. Okay, this is very important. Now, triglycerides or hypertriglyceridemia is a major risk factor for pancreatitis. Okay, so the more triglycerides that you have, the more the risk that you have pancreatitis. However, for coronary atherosclerosis or atherosclerosis in general, it's usually from cholesterol. The more cholesterol you have, the more atherosclerosis that you have. Okay. This is basically type 1. Okay. Now, type 2 is divided into 2A, 2B. But usually you remember it as one entity because it's the same mutation, really, but type 2B has VLDL and it's also elevated. So now, in this disease, type 2A, it's usually in the LDL receptor or ApoB100, which is for the LDL receptor, okay? So this is basically where you have the mutation. Now, what this does is basically LDL won't be able to bind to its receptor in the liver or in the periphery. So LDL will be elevated in the blood, okay? It won't be able to go anywhere. So this causes atherosclerosis. Okay, this is a very important feature of this disease is atherosclerosis, and it's usually very early atherosclerosis. The patient's in their 20s and they develop atherosclerosis and have an MI, okay, very early on. Very important is something called xanthomas, and it causes something called tendinous xanthomas, which is usually in pictures. It shows basically an eruption of lipids happening in the elbows or in the Achilles tendon in the ankle. Okay, that's usually where it appears. Type 2B has VLDL, which carries more triglycerides. That's why you have a bit of elevation, and it might cause pancreatitis because of this, but not really. Okay, it's not as much as, for example, type 1, which has a lot of triglycerides. Okay, so that's basically type 2A and type 2B, all right? Remember that this one is also called familial combined hyperlipidemia because it has VLDL, and this is just called familial hyperlipidemia. All right. Now, in terms of type 3, it's a defect in ApoE, which causes elevation in chylomicrons and VLDL remnants. Okay. This is also what we call dyslipoproteinemia. All right. The thing about them, you probably won't be asked about this subtype. It's usually this one, or these two. Okay. You probably won't get anything for type 3. All right. So again, it causes elevation triglycerides mainly because of chylomicron VLDL, and it causes xanthomas, and there's a risk of pancreatitis. Okay, again, it's not as important to remember this one. Very important to remember these two. Okay, now type 4 and 5 basically are defects in VLDL breakdown. Okay, so VLDL will maintain in the bloodstream, and this also causes high triglycerides, okay? Now, type 5 has a lot of chylomicrons with it, so chylomicrons won't be able to get degraded as well. So this causes very high amounts of triglycerides, and this causes pancreatitis, all right? That's pretty much basically the familial hyperlipidemia. Remember type 1, type 2A, and slightly about type 5, okay? Because it causes the pancreatitis. This one is also called familial hypertriglyceridemia because it has elevated triglycerides and it's isolated. It doesn't really cause much of cholesterol increase. Okay. Does this make sense to you guys and what to remember? Cool. Now, how do you reduce all of these things? Okay. The main drug that we use for hyperlipidemia, typically statins. Okay. Statins, in the medication name, it has the word statin. Okay, what is the mechanism of action? It inhibits HMG-CoA reductase. Now, what will HMG-CoA reductase inhibition do? It will basically inhibit the endogenous synthesis of cholesterol. This is the best agent to give. That's mechanism number 1. It decreases cholesterol synthesis. Now, what will this do in the body? The body will see, and especially the liver, will see that the cholesterol levels in the whole body is now low because you just inhibit it. So what will get upregulated as a response? The LDL receptor, okay? Now, what happens when LDL receptors get upregulated? It will take more LDL from the bloodstream, okay? So this is why it is the best drug to give for hyperlipidemia, statins, okay? 2 effects. Number 1, which is its main direct effect, which is inhibition of cholesterol synthesis through HMG-CoA reductase. The indirect effect is upregulating LDL receptors, which brings in more LDL from the bloodstream. Okay, this is the main mechanism of action. In terms of its side effects, two side effects that I want you guys to remember and memorize. Number one is it causes elevation of a certain lab enzyme. What is that enzyme? Affects this organ. So what will you see elevated? The liver, yes. So it causes mild hepatotoxicity. It's not really as seen, so you monitor it by doing ALT and AST levels. Usually more accurate is ALT. You need to do ALT monitoring for these patients. This is a very common question Dr. Dilip likes to ask. Okay? ALT. All right. So you need to monitor it. The other thing is it affects what in the body? What's the other side effect? Myalgia, good. Or myopathy, perfect. So you might see elevated, for example, CK-MB, all right? So myopathy. This is also very rare. So it has mild hepatotoxicities. You'll see elevated LFTs. You need to monitor it, okay? Now, this drug usually given to patients who have coronary artery disease. One of the main drugs you give it once they have coronary artery disease, you give it. You have hyperlipidemia, and there's a certain level you guys don't need to know for amount of lipids. You have to give statins. It's one of the best medications to give for hyperlipidemia, decrease mortality. Now, something else, as I mentioned, is at the level of GI, these two medications. So you have number one is bile acid resins. What are bile acid resins? What does bile do anyways? Bile will allow you to reabsorb or absorb lipids from the GI onto the bloodstream, okay, to be carried by chylomicrons. Now, bile, how it works is it goes all the way to the terminal ileum, and at the terminal ileum gets reabsorbed back to the liver. This is what we call enterohepatic circulation. This enterohepatic circulation is very important because it's the main, basically 90% of bile acids gets reabsorbed, okay? So what you can do is inhibit that by binding to bile, okay? Which is what we call a resin, okay? It basically binds the bile and allows it to be basically secreted or excreted in the stool, okay? So what will this do at the level of the liver? Liver will sense that the bile is low, so it will basically cause more cholesterol synthesis, okay? And more cholesterol used up by the liver. If the liver is using up more cholesterol to synthesize more bile acids in the whole body, systemically, cholesterol will go down. This is the mechanism of bile acid resins. Another way, simply, is you, in the brush border, you just inhibit cholesterol absorption, which is through ezetimibe. For bile acid, just remember bile as chole, okay? As in, you'll take this in GI. But you can remember cholestyramine, cholesevelam, or cholestoppol. Usually you just memorize cholestyramine, okay? So these are the two ways. In terms of its side effects, very easy. If you have lipids in the stool, this will cause an osmotic effect, okay, which will basically bring more water into the lumen of the bowel. So it causes diarrhea, okay, and GI upset. This is the main side effects of these medications, okay? And because you're decreasing absorption of other vitamins, you have some vitamin deficiency, which is in vitamin A, D, E, and K, okay, which are the fat-soluble vitamins, okay? And that's basically that. Now, the other medications that you can give is, for example, fibrates, which has fibrate in the name. Now, what do fibrates do? They upregulate PPAR alpha, okay? Now, PPAR alpha will activate lipoprotein lipase, which will further break down lipids, okay? That's basically what it will do. And it will basically, also another very important effect is it induces HDL synthesis, okay? Now, for these patients, it's very important to not give fibrate with what other medication? You cannot combine fibrates and what other medication because of its side effects? Statins, excellent. You cannot give fibrates and statins. Why? Because they both cause myopathy. So you will attenuate this effect. Okay, perfect. Now, because of this HDL synthesis, I want you guys to remember it's one of the best drugs in increasing HDL. Okay, so that's basically that. Now, the other one is niacin, is another drug, and it basically inhibits hormone-sensitive lipase. and inhibits lipolysis. And this will basically reduce the amount of VLDL synthesis, okay? Now, niacin, an important side effect of it is flushed, like basically flushness in the body and especially the face because of a certain vitamin. Now, you can prevent this by giving what? Aspirin. Do you give it before or after you give the niacin? Before, excellent. You give NSAIDs, aspirin, before niacin to prevent the flush face, okay? Because it's prostaglandin mediated, and as you know, NSAIDs inhibit cyclooxygenase, which will decrease prostaglandins, okay? Now you have monoclonal antibodies, which is basically anything that ends with MAB, okay, is a monoclonal antibody. And this inhibits PCSK9, okay? This will basically, what will this do is this will basically inhibit the degradation of LDL receptors. So LDL receptors will stay. This will absorb more LDL from the bloodstream or from the whole body, which is something really good because you want to decrease the amount of LDL, okay? So that's basically what these drugs do. It activates LDL degradation, which increases the amount of LDL that goes from the bloodstream. However, these are rarely given, like in practice, because anything, again, that ends with MAB is a monoclonal antibody, which is more expensive. Okay, so you don't really give this drug. Okay, now other not medications, but usually supplements that you can give is fish oil or omega-3. Still studies are being done on it, so it's not really that known to what it can do. But these are the main lipid-lowering agents. Remember how the mechanism of action, and very important, is some of these side effects. These are very important side effects, okay? We're done with lipids. Now we'll move on to hypertension, okay? So now, hypertension is basically elevated blood pressure, okay? Now, how can we define hypertension? Based on the blood pressure reading. If we have anyone that has a blood pressure above 130/80, this is hypertension, okay? 130/80, okay? Above that is hypertension. Below that, if it's above 120, if it's above 120 systolic, but not above 80 diastolic, this is elevated blood pressure, okay? Now, as I said, above 130/80 is hypertension, okay? 130/80. Okay, and it's either or, it's not and, it's either above 130 or above 80. Okay, this is hypertension. If it's above 140/90, this is stage 2. Below that is stage 1. So stage 1 is 130 to 139 or 80 to 89. Above that is stage 2. Okay, so this is how we can define hypertension. If I give you a scenario where a patient comes to your clinic, okay, and you do a reading, and it gives you a reading of 130/85. Does this patient have hypertension? And this is only one reading. Yes or no? So the answer here is no. Okay. Although they have a high blood pressure, and it makes sense that it's defined as hypertension, but one reading is never enough to diagnose hypertension. You need to do a second reading, okay? They need to come back later on, you need to do the blood pressure again. Or even better is something called ambulatory blood pressure monitoring, which is basically you give them a blood pressure cuff for 24 hours. So they go home and everything, and you measure the blood pressure. Again, if it's above 130/80 average in the ambulatory, hypertension, okay? Good. Now, hypertension can be classified into two basically types: primary hypertension and secondary hypertension. Secondary hypertension is due to what? Usually an underlying disease. What is the most commonly associated underlying disease that causes secondary hypertension? Excellent. Obstructive sleep apnea. Perfect. Is the most common disease that causes secondary hypertension. Secondary hypertension is basically hypertension caused by a disease. You can identify the cause of hypertension. This happens 10% of the time. 90% of the time, it's primary hypertension, which means we don't know actually what the cause is, okay? So this is what we call primary hypertension. Usually, primary hypertension presents in elderly patients, like older patients. It's an age-related. And in secondary, you try to investigate it if it's a young patient below the age of 30 that developed hypertension, or signs and symptoms of secondary causes of hypertension. So for example, obstructive sleep apnea, obese patient keeps waking up at night, snoring at night very loudly, and in the daytime, they keep sleeping, okay? Obstructive sleep apnea. Or other diseases such as bilateral adrenal hyperplasia, Cushing's disease, a bunch of different diseases, hyperthyroidism, or medications, okay? Do you need to remember all of that? Not really. Remember, the most common disease that causes secondary hypertension is obstructive sleep apnea. And give me one medication that can cause hypertension. NSAIDs, okay? I want you guys to remember NSAIDs, all right? Remember NSAIDs for a cause of secondary hypertension, okay? Everything else, primary hypertension, okay? Now, two diseases that are basically can make it more difficult to diagnose hypertension is masked hypertension and white coat hypertension. Masked hypertension is basically in the office, in the clinic, you measure their blood pressure and it's normal, okay? But when they tell you that at home, it's elevated, okay? Or when you do the ambulatory blood pressure monitoring that I mentioned, the 24-hour reading, it's elevated. This is what we call masked hypertension, okay? This, you start to treat it as hypertension, okay? If you don't have this, then you need to check other things, all right? Check why is this happening? All right, he's normal, okay? If you don't have this elevation, he's normal, okay? The other thing, this is very rare. The other thing that can happen is in the office, in the clinic, they have high blood pressure, but at home, it's normal, okay? This is probably due to anxiety from being at the office, okay? That's why even if this happens, it's usually lifestyle, okay? And you basically just detect if it progresses or not, all right? If this doesn't happen, if you have elevated blood pressure even at home and in the office, this is hypertension, okay? I want you guys to recognize this one. Very important. In the office, it's elevated. At home, it's not elevated, okay? This can come in your exam, all right? This one is very rare and most likely won't ask you about this, all right? So now, how can you, yeah, basically just send them home with advice. The advice is usually, I'm gonna see you in 1 year, and if they're obese or have other disease like symptoms, not symptoms, but if they're obese and poor lifestyle, just tell them, try to fix that as much as possible, and I'll see you in a year. That's it. Okay. So now, how do you manage hypertension? Okay. For patients with normal blood pressure, you monitor them as you do. Okay. So they're fine. Now, how about if it's elevated blood pressure? If it's elevated blood pressure, which is, as I mentioned, 120 to 129 and above and below 80. It has to be below 80. You first always start with a lot of these metabolic diseases such as hypertension, hyperlipidemia, and diabetes. You start lifestyle, okay? How can you control hypertension lifestyle? Weight loss is the most important thing. You lose weight, okay? And basically, there's something called a low-salt diet or something called a DASH diet that you can give to these patients. The most important thing is lose weight, okay? This is non-pharmacologic therapy, okay? And you reassess them. This is for elevated blood pressure, not hypertension, which is above 130 over 80, okay? At this point, you basically have to assess if they have other risk factors, if they have hypertension, if it's stage 1. You need to assess if they have other risk factors. If they have hyperlipidemia, diabetes, and are at a very high risk of developing strokes, myocardial infarction, you start therapy, okay? You start therapy. If not, then you can basically give them lifestyle modifications, and if they don't fix up, then give medications, okay? But here you start giving them medications if it's a yes, all right? For stage 2 hypertension, which is above 140/90, you start medications immediately, okay? With obviously lifestyle modifications. Now, what are these medications? You have many, basically, medications that you can give for hypertension. I want you guys to remember the first line medications, okay? And obviously I have slides for all the medications and side effects and everything. But so I want you guys to remember, number one thing in hypertension is the most important implicated pathway that controls blood pressure is RAS, renin-angiotensin aldosterone system. So number one is you inhibit that, okay? You want to inhibit that. So which class of medications inhibits RAS? ACE inhibitors, give me the other ones. ARBs and direct renin blockers, okay? Good. You want to inhibit this. The other thing that you want to do is you can give diuretics, which is basically decrease the volume and decrease the sodium in the blood, okay, which is good. What are diuretics that you know? There's two main ones that I want you guys to remember. Thiazides and loop diuretics. Excellent, good. And there are many other drugs that can also control. And one other thing is you want to vasodilate, okay, the blood vessels. What's one drug that can vasodilate blood vessels and has an effect on the heart? I want to mention that. And has effect on the heart. Yes, calcium channel blockers. Good. These are the first line treatments of hypertension. Beta blockers are not. Okay. So again, ACE inhibitors, ARBs, thiazides, loop sometimes, and then calcium channel blockers. These are the first line medications. Usually you give one of these. Then there are other medications that you can give depending on risk factors that the patient has. Beta blockers is one. And you can give, for example, hydralazine, nitroglycerine, and some other stuff. I'll explain when you give these drugs. So to begin, we'll start with the diuretics. Diuretics, you guys mentioned, thiazides and loop diuretics. First, let's talk about thiazide. They have the word thiazide in the name of the medication, so that's an easy way of remembering it. Now, for thiazides, where in the kidney does it act on? What is the channel or transporter? It's in the slide. Let's mention it. The distal convoluted tubule, excellent. And it inhibits the sodium chloride co-transporter. Okay. This is, as I said, first line. Okay. Now, if a patient has gout, hyperuricemia, do you give thiazides? Yes or no? No. Excellent. Why? It causes hyperuricemia. Perfect. If a patient has osteoporosis and low calcium with hypertension, which drug do you give? Thiazides. Excellent. These are the major two factors you need to remember. Major two is if someone has osteoporosis and hypertension, you want to give them thiazides. Why? Because it increases calcium absorption. Do you guys know the mechanism of why there is hypercalcemia with thiazides, right? Yes or no? If you guys don't, I'll explain. Okay, cool. Okay, so this is why it causes hypercalcemia. An important other side effect is hypokalemia, okay? Hypokalemia, there's two mechanisms. One, because of aldosterone, decreases aldosterone through a mechanism. It causes aldosterone to basically act, and aldosterone will cause hypokalemia, more potassium to be excreted, okay? The other mechanism is similarly to how calcium is there's hypercalcemia, the sodium potassium ATPase, more potassium needs to move into the cell and less potassium gets excreted. Okay, so that's the two mechanisms for hypokalemia. It also will increase LDL, so that's something important about it, and it causes hyperglycemia. So this is something important to remember for a patient who has diabetes. Okay, now moving on, you have loop diuretics. Loop diuretics affects which part of the kidney? Ascending loop of Henle. Good. It inhibits the sodium potassium 2 chloride channels. Okay, the co-transporter there. Again, causes diuresis. Important side effect of loop diuretics is autotoxicity. It's very specific for loop. Everything else, you can also see it in thiazides. Hyperuricemia, hypokalemia, hyperglycemia, and so on. Autotoxicity is a very specific sign, okay? And I want you guys to remember autotoxicity for loop diuretics. Another thing about loop diuretics is it's very good for heart failure, and I'll mention when it's given for heart failure and why it's good for heart failure, okay, later on. Another class of diuretics not routinely given for hypertension is potassium-sparing diuretics. So this doesn't actually have an effect on potassium except for spironolactone because it inhibits aldosterone, so it can cause hyperkalemia. But other than that, because it doesn't cause hypokalemia like these two, okay? So you have spironolactone, eplerenone, and then the endothelial or epithelial sodium channel transporters, blockers, okay? Now, these medications are more routinely given for heart failure, okay? And I'll mention why it's given in heart failure later. And it causes some side effects. A very basically specific side effect that I want you guys to remember is gynecomastia, okay? Breast tissue, okay? Specifically in males, okay? This is one side effect I want you guys to remember for spironolactone, okay? So I mentioned it here, but cardiac remodeling is a very good effect from spironolactone. That's why we give it for heart failure. Now, the other medications is RAS inhibitors. For RAS inhibitors, you have firstly ACE inhibitors, which ends in pril, okay? So all captopril, enalapril, lisinopril, all these medications. They inhibit the conversion of angiotensin 1 to angiotensin 2 in the lungs usually. Now, what will this angiotensin 2 do? Usually, it goes to the adrenal gland, adrenal cortex, and causes aldosterone to be released. This will be inhibited, so you have less aldosterone. So it causes more sodium and water loss. That's its effect, number one. Number two is vasodilation, okay? These are the two effects. Very important to remember about ACE inhibitors. What is the most common side effect of ACE inhibitors? Dry cough, good. How do you manage a patient who's taking ACE inhibitors and have dry cough? What will you do for them? Switch to ARBs. Excellent. Good. Perfect. This is an important concept to remember. You have to switch to ARBs. Okay? ARBs will not have this effect. Another thing is this bradykinin can cause a very rare side effect, very, very rare, called angioedema, which is basically you'll see very big swelling in the face and the lips, and it's a very like characteristic image. This will not happen with ARBs, so you can also use ARBs, okay? So that's basically that for ACE inhibitors. Other than that, because of low aldosterone and inhibition of aldosterone, you'll have hyperkalemia as an important side effect. Hypotension because it causes vasodilation, so obviously, and decreased blood pressure. And that's pretty much the important side effects here. Now, ARBs inhibit the angiotensin 2 receptor, same effects. However, it has no effect on bradykinin. That's why it does not have dry cough or angioedema, okay? So that's basically the ARBs. Direct renin inhibitor inhibits renin release or conversion of angiotensin 2 to angiotensin 1 is aliskiren. This is not routinely given, usually in practice, and there's not much to that drug to remember. There's one thing I want to remember to all of RAS inhibitors. What is one condition that is an absolute contraindication for all of these drugs? Pregnancy. Excellent. You cannot give these drugs in pregnancy. You need to remember this. The reason why, I don't know if they explained it, but basically it affects kidney development in the fetus. Okay? Affecting kidney development will cause a whole lot of complications, oligohydramnios and some other stuff. So you need to prevent this by just not giving any of these medications. Okay? So in pregnancy, you have other medication. I'll mention which drugs you can give. Okay? So that's that. Then, as I mentioned, you have calcium channel blockers, which will cause vasodilation. And calcium channel blockers, there's two types. Dihydropyridine, which acts on the heart or the smooth muscles. Dihydropyridine. Smooth muscles, good. So periphery. And non-dihydropyridine acts on the heart, okay? So this simply, you have the dihydropyridines, nifedipine, anything that ends with dipine, okay, to remember that, will basically cause vasodilation, okay? And it's selective to the blood vessels, okay? And this is through L-type calcium channels. In the heart, you have two non-dihydropyridine calcium channel blockers, which is also what class of antiarrhythmics? I'm going to teach it later on. Class 4, excellent, good. Which is verapamil and diltiazem, okay? These are cardioselective, so it decreases the heart rate, decreases the contractility, which will decrease the blood pressure, okay? These are the two effects. Important side effects that I want you guys to remember and contraindications is number one, peripheral edema. This is one of the most common side effects of calcium channel blockers is peripheral edema, okay? Remember this. Why? Because it causes vasodilation, all right? Most likely in the periphery, okay? Now, hypocalcemia, to remember, always will cause constipation. Low calcium will cause constipation, okay? That's number two to remember. Flushing and headache because of the vasodilation. There's a rare side effect is gingival hyperplasia. Again, remember that. And very importantly is in heart failure, you have volume overload, okay? Do you want to give a vasodilator in a volume overload state? Not really, because it just makes it worse. So you don't give it in heart failure, okay? Hypertension, same thing. You don't want to give it in patients who have hypertension, okay? Now, other medications that are not routinely given in hypertension, but have specific indications and specific side effects I want you to remember. Number one, essentially acting sympathoplegic is methyldopa, which is an alpha-2 agonist, which will basically decrease in sympathetic outflow, which will decrease both vascular resistance and cardiac output, so at the heart and in the blood vessels. The main indication I want to remember is pregnancy, okay? This is one of the drugs that you give in pregnancy. Another drug that you can give is this one, nifedipine, you can give, methyldopa you can give, and then you can give propranolol and one other drug, okay? So these are the drugs. Methyldopa, you can give it in pregnancy, okay? One side effect I want to remember is this hematologic immunotoxicity. This is the one side effect I want to remember for methyldopa. Will you get asked about methyldopa? Not as much, but maybe in the context of pregnancy, okay? So next is beta blockers, okay? Beta blockers, you've studied in POD before. However, it basically reduces sympathetic outflow because of the beta receptors. Most important location is in the heart, okay? So it decreases heart rate contractility, decreases cardiac output, reduces the blood pressure through that mechanism. Now, patients with asthma, do you want to give them beta blockers typically? No, okay, because of beta 2 receptors, all right? Specifically, the ones that are not cardioselective, such as propranolol, okay? So you do not want to give it in patients with bronchospasm. Another important thing is bradycardia. Obviously, it will decrease heart rate and it will cause worsening bradycardia, okay? Now, something to remember is patients with diabetes often take insulin, okay? So when they take insulin, one important side effect of insulin is hypoglycemia. Hypoglycemia, the way that the patient can feel hypoglycemic is palpitations, okay? And they feel their heart rate, all right? So if you give beta blockers, this will mask this effect because it will reduce the heart rate, reduce the contractility of the heart. So the patient will not feel these palpitations. This is why they can mask it. So you have to be careful in patients with diabetes. That's it. Be careful. You don't have to not give it at all. You just have to be careful and tell this patient that you need to be very controlled with your insulin, basically. Okay, so that's basically beta blockers. Alpha blockers, okay, such as prazosin, trazosine. The most important thing that I want you to remember, alpha blockers will cause vasodilation. Important is what disease can you give with like to treat hypertension? What other disease with alpha blockers? BPH, okay? Benign prostatic hyperplasia. There is alpha receptors there at the level of the urethra. So you dilate that. This will cause better symptoms of BPH, okay? Benign prostatic hyperplasia. which is basically because of the prostate enlargement, it compresses the urethra. So you want to dilate that. That's basically how it treats both, okay? So you can treat both with one drug, okay? So you have as a side effect, first dose hypotension, which is the most common side effect because of alpha antagonist effect, okay? So other drugs are these. Now, these are usually never given in with patients with hypertension, but I'll explain some of them. Hydralazine releases nitric oxide. All of these usually basically release nitric oxide or potassium channel, which causes repolarization. That's basically all of it. This one, hydralazine, nitric oxide, one of the best medications to give for pregnant women. That's all that is needed to remember for this. Okay, that's for hydralazine. Other than that, an important side effect is drug-induced SLE. There will be another drug that we'll talk about in this session, which will cause drug-induced SLE, okay? And I'll question you guys about hydralazine again later on, okay? But that's basically it. Releases nitric oxide, that causes vasodilation, very good for pregnancy, okay? Then you have minoxidil, which is basically opens potassium channel, causes repolarization. This is good for baldness. Is it usually given for hypertension? Not much, okay? Nitroprusside, nitric oxide, just remember hypertensive emergency, okay? Nitroprusside. That's all you need to remember for this drug. Diazoxide, not much to remember for that, not gonna lie. Very rarely asked and rarely even given. Not gonna lie, I forgot that this drug even existed. Then phenol, which is basically a dopamine receptor blocker. It causes vasodilation. Okay, that's it. All right. You don't really, these two are not really commonly asked. This is never given, just remember for baldness. This one, hypertensive emergency. This one, pregnancy. Okay, and SLE-like symptoms. All right. This one is also somewhat of an important one because of vitamin B6 deficiency. Okay, but these are the medications for antihypertensive. Remember, these are the most importantly given ones, and the side effects are always asked about, okay? These ones are just the specific indications and specific side effects, which are like, for example, this, okay? This is all for antihypertensives. Now, let's talk about complications of these diseases: hyperlipidemia, atherosclerosis, and hypertension. This patient comes to you with left lower leg pain that occurs with walking and relieves the rest. Examination shows dry legs, shiny legs, and diminished pulses. What's your diagnosis? Excellent, good. This is peripheral vascular disease. Okay. There is one symptom that is in this scenario that is the most important and characteristic symptom, which is this. What's the name that we give for this symptom? Excellent. Intermittent claudication. Perfect. This is what we call intermittent claudication. They tell you they have pain that happens with walking, but relieves the rest. Why is that so? What is peripheral vascular disease? Peripheral vascular disease, think of this as the aorta and the iliac and femoral, okay? Just remember, just think of this. If you have a plaque, for example, in the femoral artery, okay, right here, blood will obviously flow this way, okay? Now, when you're at rest, the muscles are not contracting as much, obviously, okay? So the oxygen demand of the muscles is not high. When you start walking and physical activity, the oxygen demand of the muscles will increase, okay? With the increased oxygen demand, it will start to feel painful to contract. Another thing that happens is metabolites, okay? It gets released, however, there's limited blood flow. So there will be accumulation of metabolites, causes pain, okay? These are the mechanisms to why there is intermittent claudication. When they rest, the oxygen demand goes down, and there's going to be washing of the metabolites, so the pain goes away. Okay, relieves of the rest. This is the important sign of peripheral vascular disease. Okay, other signs of peripheral vascular disease is, for example, a very dry, shiny legs. Why? Is because of diminished blood flow. Okay, it causes a very dry skin and very cold skin as well. Okay, why is it shiny and there's hair loss? Because of decreased blood supply to these, for example, the hair follicles and so on. So there is decreased um, vascularity there. There is also diminished pulses, which is very important. And there are usually certain blood vessels that you check the pulses from, which is starting from proximal. You have, for example, here you're going to have the femoral, then at the level of the knee, you'll have the popliteal, then the posterior tibial, then the dorsalis pedis at the foot. Okay. So these are the pulses. Now, another thing is you might see ulceration because, again, decreased blood supply to that area. Any injury won't get good blood supply, so it starts to ulcerate, okay, and start to get infected also. So that's basically peripheral vascular disease. How do you want to diagnose peripheral vascular disease? What's your next step? Excellent. Ankle brachial index. What is the cutoff number for ankle brachial index? 0.7. Perfect. Less than 0.7. Excellent. Good. So as the ankle brachial index is you basically check the blood pressure of the ankle and the brachial. Okay. Not only the blood pressure, the pulse as well. So you check the pulse of both. Normally should be 1. They should be somewhat similar. Okay. However, when the ankle goes down because of peripheral vascular disease, the ratio will go down. Okay, between these two values, the ankle and the brachial. Brachial is R, ankle is low, and then the foot. So it will go down, the ankle. So this ABI will go down, and less than 0.7 is diagnostic of peripheral vascular disease. Can you use imaging modalities? Yes. What imaging modalities can you use to diagnose peripheral vascular disease? Non-invasive, very easy to use, ultrasound. Okay, you can check Doppler ultrasound to see the flow. Okay, other than that, you have something called angiography, which you inject a dye in the blood vessel and you do a CT and you can see the narrowing and stenosis that occurs. Okay, that's basically that. How do you treat peripheral vascular disease? Depends on the severity, but usually you give lifestyle modifications and you treat the underlying diseases such as you give statins, you give antihypertensives, and so on. And if it gets very bad, if it's clogged because of a thrombus, you can give fibrinolytics, okay? And I'll explain what they are later. Or you can basically do stenting, okay? That's basically how you manage it. Don't remember that too much. Remember the sign, which is this, very important sign, which is intermittent claudication. How do you recognize it? And the ankle brachial index is very important for you guys to remember the 0.7, okay? Now, another pathology that can happen because of these diseases is aneurysm. Aneurysm is defined as dilation of the blood vessel wall, okay? So there are multiple different ways we can classify it, whether it's true or false. True involves all the layers, so the intima, media, and adventitia. False will probably involve maybe the intima adventitia or media adventitia, okay? Not all of them. That's the main point. This is what we call a pseudoaneurysm, okay? The other way is by how much of the wall is involved circumferentially. If it involves the entire wall circumferentially, this is what we call a fusiform aneurysm. And then this will involve one part of the wall, okay? This is what we call a saccular aneurysm. Now, where do these aneurysms occur? All of these. Most common locations is brain and aorta. It can happen anywhere else, but brain and aorta is what you need to remember. In the brain, it's typically a saccular aneurysm. It's a typical saccular berry aneurysm. And which artery in the brain is typically involved? Anterior what? Is it anterior cerebral or anterior communicating artery? Anterior communicating artery. Okay, it's anterior communicating artery. Okay, anterior cerebral arteries, between them is the anterior communicating artery. Okay, that location is the most common. Rupture causes subarachnoid hemorrhage, if you remember from neuro. Okay, so now let's talk about it in the context of the aorta now. Remember this location though, okay? In the aorta, you can have it ascending, okay, aortic aneurysm, or descending aortic aneurysms. Or in the abdominal region, what we call is an abdominal aortic aneurysm, or AAA. Okay, so at the level of the ascending aorta, I want you guys to remember some conditions that can cause it. Okay, so first of all, hypertension. Very easy to remember because the high amount of blood pressure can easily cause damage of the blood vessel, which will cause dilation. Okay, that's number one. Number two is something called syphilis. Syphilis has three phases. You'll learn this in endoRepro. The third phase is something called tertiary syphilis. It can cause this. Another one is tuberculosis. Another disease is Marfan syndrome, which causes cystic medial necrosis. Excellent. And I'll test you guys in the next slide. Okay, what is the next slide? I'll mention it. Okay, what is cystic medial necrosis? And then you'll have descending, okay, which is AAA, abdominal aortic aneurysm, which is commonly caused by atherosclerosis, hypertension, very circle atherosclerosis for the abdominal aortic aneurysm. And very important is smoking. Okay, smoking is a very big factor for an abdominal aortic aneurysm. Okay, the problem with this is it can rupture. Now, how can you tell about an abdominal aortic aneurysm by signs and symptoms? Is usually a pulsatile mass in the abdomen, and if it ruptures, it causes hypotension and so on. Okay, so that's basically that. Now, what cause of abdominal aortic aneurysm is seen in this patient, or thoracic even? Marfan, which causes what in the aorta? What happens to the walls? Cystic medial degeneration. Okay, this is Marfan syndrome. It's because of decreased elasticity of the aorta because of a defect in fibrillin. Okay, fibrillin 1 gene. All right, that is Marfan syndrome. It causes hyperelasticity, and you can see a Marfanoid feature, which is very long arms. Like the arms are way bigger than the size of the legs and so on. And as I said, hyperelastic. Now, the other entity is dissection. Dissection is basically where you have a tearing of the aorta. Okay. Basically, wall will accumulate between the intima and the medium. Okay, and will continue accumulating, causing a false lumen. Okay. Now, this can expand and can rupture or occlude the lumen and decrease blood supply. Very important is it goes down all the way to the kidneys and causes a kidney injury. Okay, because it decreases blood supply going to the kidneys. That's one of the important ones, or it causes stroke. This is how it's basically fatal and rupture. Now, important for you guys to remember is how can you classify abdominal aortic dissection? Is you have two classifications, the Bakey and Stanford classifications. You need to be able to know how to classify it. It will come in the exam channel. Okay? Remember this. The Bakey has three: type 1, type 2, type 3. Type 1 DeBakey is ascending and descending aorta. That's DeBakey 1. DeBakey 2 is ascending. It has to have the ascending. Okay? It has to only include the ascending. Okay? That's DeBakey type A. Type 1, sorry. Type 2, sorry. DeBakey 1 is ascending and descending. Type 2 is ascending. Type 3 is descending. Okay? That is DeBakey. Stanford is only two types. Type A, type B. Type A is it includes ascending. It has to have the ascending aorta. Okay? It does not matter if there's the descending aorta. As long as the ascending aorta is there, it's type A Stanford. Okay? Remember A for ascending aorta. It has to involve the ascending. Type B is it does not have the ascending aorta. That's it. So again, the DeBakey 1, ascending and descending. The DeBakey 2, ascending. The DeBakey 3, descending. Okay? Stanford A has to have ascending. If it does not have ascending, it's type B. Is this clear for the dissection? You need to be able to identify these. The other thing is how can you know that the patient has dissection? The pain is a chest pain, as usually central chest pain, is a stabbing, tearing sensation. This is a very Very important description. Stabbing, tearing sensation that radiates to the back. This is how aortic dissection presents. Another sign of it is something called radio delay. The blood pressure in the arms will be different. So one arm will be elevated more than the other, or vice versa. Okay, this is radio delay. This is another sign of dissection. When does it happen? What are risk factors? Hypertension, atherosclerosis, these risk factors. Okay, this is aortic dissection. Another sign is something that you can see. What is this disease? Number one, as we just mentioned, it's aortic dissection. What can we call this sign? Perfect. Widened mediastinum. The mediastinum, typically, you'll have a small aortic notch over here, which is for the aorta, and then it goes down like this, okay? This is typically how the mediastinum should be, and it should be like this. However, in patients with aortic dissection, it's wide, okay? Very wide, okay? So this is widened mediastinum, aortic dissection, all right? Know these signs and features and the classification of dissections. Now we'll go into vasculitis. So which of the following basically affects elderly patients, causing headaches? A or B? A. What is A? Giant cell arteritis. Excellent. So giant cell arteritis affects elderly patients, typically affects branches of the carotid artery. Okay. Typically it presents as headaches, very like sensation of pain over here. And what's very important complication that can happen with giant cell? Blindness. Excellent. Because it involves the ophthalmic artery. Excellent. Now, that's number one. Number two is how can you identify it histologically? Give me the feature that you can see here. From the name of the disease, what can you see here? Giant cell. Excellent. Now, the other entity over here also has giant cell. So what other thing can you see that differentiates it? This was shown over here. Fragmentation of the elastic lamina. This is crucial to remember, okay? This is giant cell arteritis, okay? Elderly, the branches of the carotid artery frequently present as headaches. Complication that's important is blindness. Histologically, you see giant cell and fragmentation of the elastic lamina. Management, steroids, okay? That's it. Now, what is B? Takayasu arteritis. Excellent. Typically, present in younger females. Typically, the epidemiology is always mentioned as like young Asian females, and it involves the proximal aorta, okay, or the proximal aortic vessels. Now, when it involves the proximal aortic vessels, this basically will impede blood flow to the arms. So when you check the pulse of the arms, it will be diminished. This is also what we call pulseless disease, okay, Takayasu arteritis. So that's basically how to remember it. Histologically, giant cells, okay, as you can see, these big cells, but it does not have fragmentation of the elastic lamina. That's how you can remember this disease, basically, in a nutshell, okay? What can you see in this patient?
Leukocytosis.
Good. Not leukocytosis, the next one is polyarteritis nodosa. Now, polyarteritis nodosa, does it affect large, medium, or small blood vessels?
Medium.
Medium, excellent, good. So it affects medium blood vessels. Now, I want you guys to remember that it affects usually the kidney, the skin, the GI, and many areas, but usually in a lot of scenarios, the kidney is very involved. Now, polyarteritis nodosa, histologically, I want you to remember two features. Firstly is what is seen in this basically the wall, the lining of the blood vessel. Fibrinous necrosis. Excellent. Number 2 is in the lumen. What's happening? Okay, this is luminal thrombosis. Okay. That's basically what you see in polyarteritis nodosa, medium-sized blood vessels. Okay. What is the other medium vessel vasculitis presenting with these?
Kawasaki.
Kawasaki disease. What is this sign? Strawberry tongue. Excellent. Good. There's a mnemonic to remember signs and symptoms of Kawasaki. You guys don't really need to go into details with it, but it can cause conjunctivitis, a rash, edema in the hands, and causes the characteristic strawberry tongue. The feared complication of Kawasaki disease, exactly, crash and burn. Perfect. And fever, very high fever, okay? The very feared complication of Kawasaki disease is coronary artery aneurysm. Okay, so it can cause fatal MI in young patients. Okay, this is Kawasaki disease. Now we go into the small vessel vasculitis. What is this one? Yes. What's another name? Microscopic polyangiitis or leukocytoclastic, cytoclastic polyangiitis. Now, to remember this, the small vessel one, it affects skin, GI, kidneys, many places. Okay, that's number 1. Number 2 is it has neutrophils, but does this have granuloma? Yes or no? No, it's a non-granulomatous. Okay, it has neutrophils, as you can see some of the neutrophils here. This is another one, and then leukocytes, for example, right here. Another thing is you need to identify the small vessel ones based on its marker. You have 2 markers, P ANCA or C ANCA. Which one is in this one? P ANCA, perfect. This is very important to remember the P ANCA, C ANCA stuff. Okay, you need to remember this. The location is relevant in this one. What is this one? Granulomatosis with polyangiitis affects 3 locations. Number 1, upper respiratory tract, as you can see in the nasopharynx and the pharynx and the upper trachea, for example, and you can see some ulceration happening, and affects the lung. Usually affects and causes cavitations in the lungs. Okay. Another location is the kidney. All right. Now, this one from the name is granulomatosis. So it causes granuloma. And what do you see with granulomas? What are these? Giant cells. Perfect. Is it P ANCA or C ANCA? C ANCA. Perfect. Good job. That's it. Okay. This patient has asthma, allergic dermatitis, basically allergic skin, irritation. What does he have? And vasculitis. Churg-Strauss. Excellent. So this is Churg-Strauss. Okay. What cell is accumulating in Churg-Strauss? As I said, it's associated with asthma. This is very important. Asthma. So eosinophils. Good. And it's P ANCA positive. The only one that's C ANCA is granulomatosis. Okay. GPA. Remember that. Okay. Now, what is this? Berger's disease. Excellent. Good. What factor, the most important risk factor for Berger's disease? Smoking. Remember that a male smoker presents with this gangrenous tips of the finger. This is Berger's disease. Okay. That's it that you need to remember. Or the other name is thromboangiitis obliterans. Okay, but just remember Berger's. Okay. How about this? Raynaud's phenomenon. Now, Raynaud's, there's primary Raynaud's, which is basically it happens for no reason, or secondary Raynaud's, which happens with other diseases, such as systemic sclerosis and other stuff that you learn in MSI, inshallah, when you come there. So this is Raynaud's phenomenon. It usually presents as a sequence going from pale skin because of vasospasm. It turns pale, then it turns blue because it accumulates deoxygenated tissue. It turns blue. Then when the vasospasm ends, it's basically gets flushed with blood, oxygenated blood, so it turns very red. It's usually in this type of sequence. Okay, but this is Raynaud's phenomenon. Primary Raynaud's happens, for example, characteristically is cold. Okay, they go outside, they have vasospasm, and this happens, or they wash their hands with cold water. This is the characteristic, basically, way they describe it. Okay. Now going on to the endovascular, we have DVTs. DVTs happens, basically, it's a blood clot that happens in the deep veins in the lower legs. Okay. The risk factor for DVT is what I need you guys to fully remember, which is Virchow's triad. Okay. Stasis, most commonly long flight or a drive, or surgical, okay, so post-operative. Hypercoagulable states, for example, either they're taking medications such as OCP, pregnancy, or other coagulation diseases. So, for example, factor V Leiden is a very common one, or endothelial damage, okay? These are the three main, basically, risk factors or classes of risk factors that can cause DVTs. The presentation is very important. It's either usually unilateral, one leg that is swollen and very tender. And one of these risk factors is usually present. Either they were coming from a long flight and then they presented this, or they had an operation, or they have an underlying disease. Okay? This is what I need you guys to remember for DVT. Now, very important for DVT is what complication can happen from DVT. Pulmonary embolism. Excellent. So, what is your diagnosis here? Pulmonary embolism. Let's start from ECGs. I'm sure Leanne tell you guys this ECG, but what can you see? Firstly, what is the most common sign of pulmonary embolism on ECG? What do you commonly see? This is more rare, but you are right. You don't see it all the time. What is one thing that you always see? Not always, but it's the most frequent thing. Tachycardia. Excellent. Tachycardia. Okay. That's why we don't really usually do ECG, but it's usually to exclude other diseases such as NMI. Okay. But another thing is the S1Q3T3. Okay. So S1, look at S wave in lead one. It's basically goes down. All right. Deep S wave. Okay. This is in lead one. If you go to lead three, you'd see two things. First one is a present Q wave, very small, but it's there, and inverted T wave. Okay, this is S1Q3 T3. Now, in a patient that comes to you with either DVT or pulmonary embolism, what is one very specific lab investigation that you can order? D-dimer. Excellent. Good. D-dimer. D-dimer is very important. It's basically from breakdowns of the thrombus itself. Okay, D-dimer. Excellent. You can order ABG and it can show you some signs. However, it's not routinely always done. D-dimer is very important because it can also alter your management. So you order D-dimer. Now, in a patient that can handle contrast, you can do a CTA. What can you see? What is this type of thrombus that you can see on this CT? What is the type of thrombus that you can see? Or type of pulmonary embolism? This is what we call saddle embolus. Excellent, good. Where it basically covers the opening of both bifurcation of pulmonary arteries. Okay, and this is the worst type and most fatal type. Exactly, causes death. This is basically what we call this imaging is CT angio. Okay, and it's usually described as a spiral CT angio, and usually is what it has to have dye, which is this hyper intense area. Okay, the pulmonary artery is very white because it has the contrast dye. Okay. This is the imaging modality of choice for pulmonary embolism. If someone can't handle contrast because of kidney disease, what modality can you use? Other than echo, echo's good. Very specific for pulmonary embolism. VQ scan, good. Which will show a ventilation perfusion mismatch. Okay. In pulmonary embolism, ventilation is fine. Alveoli is fine. There's no obstruction there. However, perfusion is the issue because of the thrombus. So here you have normal ventilation. This is nuclear medicine scan. The normal ventilation, there's no defects. In perfusion, you can see clearly defects a lot of areas. Okay. And the right lung is more apparent here. Okay, so this is what we call ventilation perfusion mismatch or VQ mismatch. Okay, this is pulmonary embolism. How do you manage pulmonary embolism? Usually you break down the clot. Okay, fibrinolysis, if it's a big clot like this. Or majority of the time, it passes on its own. It's asymptomatic if it's very small. But for these patients, after you acutely manage pulmonary embolism, you give them antithrombotics. Okay, which ones you don't really need to know specifically, but you need to know the drugs. Okay, you don't need to know which one do you actually have to give. Okay, which will bring me to these. Firstly, you all know platelet mechanism, very easy. Once you have exposed subendothelial matrix, you have von Willebrand factor that is exposed. GP1B will bind to von Willebrand factor and it causes activation of the platelets. One important part of activation of platelets is these ADP receptors. Okay. Another thing is this ADP receptors, once adenosine and all that binds to its ADP receptor, it causes more GP2B3A receptors to be expressed. This causes platelet aggregation. So with fibrinogen, with other platelets. Another important thing is in platelet activation itself, you have cyclooxygenase because you need to produce thromboxane A2 for the activation. This is basically platelet mechanism. You inhibit it by multiple mechanisms. Number one is inhibit the activation by reducing thromboxane A2 by giving what medication? Will inhibit aspirin, okay? NSAIDs, good. Or you inhibit ADP receptors, which is with what? Or another name for these receptors are purine 2Y12 receptors, such as clopidogrel. Or you inhibit GP2B receptors. Another thing is you inhibit phosphodiesterase, which will increase cyclic AMP, which will inhibit all of this. Okay, so these are the 4 ways you can inhibit platelets, which we'll talk about right here. And there's other like weird drugs, but anyways. First of all, aspirin. Aspirin, as I said, inhibits cyclooxygenase and inhibits the thromboxane A2 release. Now, this is in a very low dose, okay? Why is once you absorb aspirin in the GI circulation, the portal circulation, it inhibits platelets there, okay? It's all you need. A higher dose will cause systemic adverse effects, as you can see here. Do you need to remember these? Not much, okay, for now. But these are the adverse effects if you give a higher dose. Another thing is it irreversibly binds. So you give it once a day, even though its half-life is like 2 hours, you only give it once, okay? Because it reversibly binds it. Now, it's the drug of choice to give in acute coronary syndrome. I'll explain what drugs to give in coronary stenting, because typically when you give or when you treat patients with acute coronary syndrome with stenting, they have something called stent thrombosis that can happen as a complication. So you prevent it by this. And it's very good for occurrence of thrombotic strokes. Anyways, then you have clopidogrel, okay, or prasugrel. I can never pronounce this drug, but anyways, it basically binds the ADP receptors, P2Y12 inhibitors, and basically this will cause decreased expression, as I mentioned, of GP2B3A receptors, which will decrease platelet aggregation, okay? This is usually given as dual antiplatelet therapy with aspirin, okay? Then we have abciximab, okay, monoclonal antibody, I think. It blocks the GP2B3A receptors, and this basically decreases the platelet aggregation. Again, for unstable angina and all that stuff. Then you have the phosphodiesterase inhibitors, which will increase cyclic AMP, which will decrease platelet aggregation and activation. Okay. Now you have these drugs, the protease receptor or protease activator receptor 1 antagonists, which will basically inhibit platelet aggregation. And the contraindication is hemorrhage. All of these drugs, side effect important to remember, bleeding. Okay, bleeding. Makes sense because it inhibits platelets. Okay, that's majority of what you need to know for antiplatelet agents. Going to anticoagulants and fibrinolytics, there are many other drugs. Okay, anticoagulants inhibit the coagulation cascade. You can do this by multiple methods. Either you have three classes that I like to mention: warfarin, okay, which inhibit the extrinsic factor and other factors, obviously. So vitamin K inhibitors. Then you have heparin, okay, and the different types of heparins. So heparins, low molecular weight heparin, and synthetic heparin. And then you have the DOACs, the direct oral anticoagulants, okay? These are more specific to specific targets. It's either factor 10 or thrombin or factor 2, okay? Let's talk about them one by one. First of all is warfarin. What is the mechanism of warfarin? Vitamin K inhibitor inhibits epoxide reductase in the liver, which will decrease the activation of vitamin K. Okay? Which factors are involved in vitamin K? Which factors are vitamin K dependent? 2, 7, 9, 10. Excellent. Is there anything else that's also affected by vitamin K and warfarin other than these four factors? No, these two. Okay? Protein C and S. This is important for a side effect. Okay? Now, what do you use to monitor warfarin? What lab test do you do? PT-INR. Excellent. Good. Okay. This is warfarin. What is its side effect? Number one, you can say bleeding, which is correct. Number two is something called warfarin-induced skin necrosis. Okay. And bleeding. Why is skin necrosis important? As I said, it inhibits the vitamin K dependent factors. It's 2, 7, 9, and 10, right? And it inhibits protein C and S. The first things to be inhibited are protein C and S. Protein C and S are anticoagulants. Okay, if you inhibit an anticoagulant, this will cause coagulation to work. So skin necrosis is because of coagulation. Okay, it's a very rare side effect, and you treat it by giving other anticoagulants with it. Okay, that's an important side effect I want you to remember. Warfarin-induced skin necrosis. Okay, because of it inhibits protein C and S first. All right, that's with warfarin. Now let's go to the heparins. Heparins, you have unfractionated heparin, low molecular weight heparin, and the synthetic heparin. The best one to give from all of them is the low molecular weight heparin. Okay, it's the better one to give. Usually heparin, you give it subcutaneously, intramuscular, subcutaneously. And for heparin, what can it do is it basically inhibits two things: factor 2, which is thrombin, and factor 10A. Okay, so it has two effects. Okay. Now, low molecular weight heparin, something to remember for it is it can be given in pregnancy. Usually patients, if they require anticoagulation, you give them low molecular weight heparin. Other than that, what lab investigation do you do to monitor patients on heparin? We said PT for warfarin, PTT is for heparin, okay? So that's that. Then we have the direct oral anticoagulants, the DOACs. There's two types, either direct factor 10A, such as apixaban, or you have the direct thrombin or factor 2 inhibitors, which is, for example, the dabigatran. Okay. Now, for these, their effects that causes bleeding and so on is better. It does not cause bleeding as much as the other anticoagulants, such as warfarin and heparin. So it's very good. Another thing is this oral. Do you need to monitor patients on direct oral anticoagulants with PT or PTT? Yes or no? No, you don't. Okay? It does not have that effect, all right, as much. It's the safest anticoagulant that you can give. Okay? DOACs. All right? So that's basically that. You can give it to patients who have DVT, PE risk. You can give DOACs. They're the safest drugs to give. Okay? Another indication that I want you guys to remember to when you give anticoagulants is in a specific arrhythmia. What arrhythmia do you have to start anticoagulants with? AFib. Excellent. You need to start anticoagulants because they have a high risk of stroke. Good. Now, for thrombolytics or fibrinolytics, you have these, which is, for example, streptokinase, alteplase, and whatever. It basically activates plasmin, and plasmin will go and break down the clot. Okay? I want you to remember that these medications, alteplase, streptokinase, you cannot give it in certain conditions, such as in a patient who has active hemorrhage anywhere, a patient who has a brain mass, who has a history of brain hemorrhage and stuff like that. You cannot give these patients thrombolytics. Okay, these are contraindications. Okay. Now going last topic in vascular is the tumors. Now, what is this tumor that you can see here? Give me the broad name of tumors. Hemangioma. If I say and give you the scenario that I have a child who had a hemangioma that grew and then went down in size over time, what type of hemangioma am I talking about? Usually on the face. This is what we call a strawberry hemangioma, okay? Typical in children, young, like infants. They have a hemangioma that grows on the face. An important sign is it regresses over time, okay? Other than that, you have cavernous hemangioma and pyogenic granuloma as another type of hemangioma. How can you tell that this is hemangioma? Hemangioma is a benign tumor of blood vessels, so it's all blood vessels. How can you tell that this is a blood vessel? By looking at RBCs inside the lumen, okay? These typically grow in size and then regress. This is more of a pyogenic granuloma, I believe, which is associated with pregnancy, okay? So this is in the image D, okay? That's basically hemangiomas. How about this? What is this? Lymphangioma. Okay. This is a lymphangioma. This is a benign tumor of lymphatic vessels. Why exactly? Good. This is a lymphatic vessel because it has no RBCs. What's happening with this baby? What is all of this? What do I call this? Cystic hygroma. Okay, this is a cystic hygroma. This happens with lymphangioma. Okay, and it's typically associated with genetic diseases, sorry, such as Turner. Okay, so this is a cystic hygroma which is basically a lymphangioma. Okay, how about this very painful lesion in the finger, glomus tumor? Okay, it's basically smooth muscle cells that are involved in thermoregulation. That's all that you need to remember. Just remember glomus tumor, finger, painful. Okay, thermoregulation, smooth muscle cells. These keywords. That's it. Okay, this is glomus tumor. How about this more malignant one? Kaposi sarcoma. Excellent. So Kaposi sarcoma, it's basically another one of the blood vessels tumors. This one is more severe. This one basically forms macules that then forms into papules and plaques and so on, which is all these papules. It's basically a tumor of spindle cells. Okay, there's a bunch of spindle cells in histology. Okay, a lot of these, which are basically imaging slides of all of the vascular tumors, you just need to be able to identify it based on image because he will give you the image. Okay. And once you see the image, you'll know. This one, spindle cells. The other one, glomus, as I mentioned, is you can see painful in the finger bed for thermoregulation. Remember these key terms with the images. Okay. How about this one? Angiosarcoma. Excellent. what is a compound associated with angiosarcoma? Or compounds? Arsenic and one other one that I want you guys to give me. PVC. Excellent. Remember these. Okay. PVC and arsenic. Is there a specific CD marker that you can target for angiosarcoma? 31. Excellent. Remember CD31, angiosarcoma associated with PVC and arsenic. Okay. That's basically the key terms that I want you guys to remember for angiosarcoma. And we're done with vascular. It took a while. Do you guys the second part of this crash course, which is the cardiac and cardiology parts? So now very simple basics that I want you guys to remember. And Leanne has already mentioned the localization of myocardial infarctions already, so I don't have to mention any of that, but just remember the blood supply. The blood supply, you have left coronary artery, right coronary artery. Left coronary artery, you have left anterior descending, which supplies the majority of the left ventricle, the anterior two-thirds of the interventricular septum, and the papillary muscle, and most of the left ventricle, as I mentioned. Okay, and it's usually the anterior portion. The lateral portion of the left ventricle is by the left circumflex artery. Now, the right coronary artery gives off the right, basically, firstly supplies the SA node and the AV node. So if you have a right coronary artery infarction, this causes basically bradycardia and fluid overload. Okay, it causes acute heart failure. Okay. Another thing is majority of the time, the posterior descending artery comes from the right coronary artery. Posterior descending artery supplies posterior 1/3 of the interventricular septum and the posterior 2/3 of the walls of the ventricles and so on. That's basically, you need to just remember the blood supply in relation to MI localization, which I believe Layan covered. Okay. Now, other than that is this stuff. Okay. The function of the heart and the contract, basically all of these. Okay. So this is all basic first year stuff, but you need to be able to recognize the different changes in the atrial pressures, in the aortic ventricular pressures, and in the heart sounds. You need to recognize a lot of these changes that happens in the level of the heart. To explain the cardiac cycle, just basics, let's start over here where you have the mitral valve will close. As you can see, you have firstly you have the mitral valve closing. Why does it close? Is because ventricular pressure will start to become higher than atrial pressure. As you can see in the ECG, QRS complex basically tells us that there is ventricular depolarization that's starting. So the first thing that happens is mitral valve closes, as you can see from S1. Then you'll have isovolumetric contraction of the ventricle. Why is it isovolumetric? It's because none of the valves are open. The aortic valve is closed because aortic pressure is still higher than ventricular pressure. And you can see it's isovolumetric, so the ventricular volume is not changing. Until the ventricular pressure is higher than the aortic pressure, the aortic valve opens, okay? Then you have rapid ejection and reduced ejection. Here, you have the T wave. The T wave is telling us there's ventricular repolarization, relaxation that's going to start. So you can see reduced ejection. The pressure in the ventricles will start to go down, 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 until it's less than the aortic pressure. The aortic valve will close, producing S2. Okay? Then you'll have isovolumetric relaxation, where the ventricular pressure is still higher than the atrial pressure, so the mitral valve will not open. Okay, until the atrial pressure is higher than the ventricular, which happens somewhere over here, where the ventricular pressure is less than the atrial pressure, so you have mitral valve opening, and then you'll have rapid filling, and then reduced filling, and then back again from the start, okay? These are basically the normal cardiac cycle. Important thing is S1 is associated with mitral and tricuspid valve closing. S2 is aortic and pulmonic valve. Between S1 and S2 is systole, S2 to S1 is diastole, okay? Then another thing that's important is the additional heart sounds. We have S3. S3 is indicating that there is volume overload, okay? Can you see this in non-pathologic states? So physiologically, yes or no? Yes. What conditions can you see S3 in, or what states can you see? Pregnant, athlete, and even in In young, for example, adults going through puberty, you might see this, okay? This is S3. Pathologic is when you have, for example, dilated cardiomyopathy. You can have S3. Now, contrary, you have S4. S4 happens when you have a very stiff ventricle, where you have your compliance is very low. For example, in hypertrophic cardiomyopathy, okay? This is pathologic, okay? So that's basically the changes I want you to. The other thing is right atrial pressure changes, okay? Which is this JVP curve. A is showing you the mitral valve, basically the atrial contraction before the mitral valve closes. C, okay, is the closure of the mitral valve when you have ventricular contraction. What happens basically is the ventricles will contract against a closed mitral tricuspid valve, sorry, because this is right atrial. So when it closes this basically it contracts against this closed tricuspid valve, it causes a recoil upwards. This recoil upwards will cause the C wave to form, okay? This is ventricular contraction against a closed valve, okay? So that's that. Then it descends down because the aortic valve will open and the blood will now eject through or the pulmonary valve, it will eject through into the lungs. Okay, so you'll have the descent in the atrium. Then it will slowly go up as a V ascend or V wave. And the V wave is basically where you have the atrium is getting all the blood. Okay, all the blood is going to the atrium and it's still not going to go to the ventricles because the tricuspid valve is still closed. When the tricuspid valve opens, you'll have the Y descent. So here, this one, the V wave is the majority, like the most highest point. And you do need to remember some of the causes of pathologic waves. Not gonna lie, I don't remember me studying them back then, but Dr. Santush always likes to like hint it. He never got it for us. So like it's your luck, okay, when it comes to this. But to really think about it, is if you have mitral stenosis, the C wave will be high, okay? That's an example of it, okay? So yeah, these are the normal changes that happens. Now, in the case of this cardiovascular or the loop, you have the same things happening. Here, we'll start over here at the start of systole, the mitral valve closes, you have isovolumetric contraction. Then the aortic valve opens, you have rapid ejection, then reduced ejection. Then you'll have isovolumetric relaxation that starts when the aortic valve closes up till the mitral valve opening, okay? When the mitral valve opening, then that's when you'll have the filling that occurs, okay? These are the normal findings. Now, this axis is basically where you have the left ventricular volume. This is higher, this is lower volume. Left ventricular pressure, higher volume, higher pressure, lower pressure, okay? This is end diastolic volume, which is basically the volume in blood that is in the ventricles at the end of diastole, okay? Before systole occurs. And this is end systolic volume. Now, you need to remember the states where you have increased preload, increased afterload, and increased contractility. You need to remember them in the context of valvular heart disease, okay? So let's go into valvular heart disease. What valvular heart disease is seen in this image, in the PV loop and in the cardiac cycle? Aortic stenosis, which causes increased afterload, preload, or contractility? Afterload. As I said, going up will cause afterload. So this is an afterload. Okay, so you'll have increased afterload, which is basically the heart now has to pump harder to overcome the high aortic pressure because of the aortic stenosis. Okay, so the ventricular pressure has to go way higher than the aortic pressure. Okay, to overcome the aortic stenosis. So the afterload is characteristically very high. Okay, how about here? What's seen in this valvular heart disease? When you have systole, there is blood going into the atrium. What does that mean? Blood is going into the atrium. Regurgitation. Good. Mitral regurgitation. Okay. The valve is not strong. So blood in systole, when the ventricles are contracting, it will seep into the atrium. So when it seeps into the atrium, you'll see a descent in the atrial pressure during systole. This is not supposed to happen. Okay. So the atrial volume will be elevated. Okay. What can you see in the PV loop? Increased afterload. Why? Is because during each systole, your volume of that blood is going to the atrium. So that causes two effects. A, it decreases the end systolic volume because more blood is moving somewhere else in the atrium and the aorta in two different places. So the end systolic volume is going to be less. At the same time, during diastole, when the mitral valve actually opens, since there's more blood in the atrium, more blood will go into the ventricles. Okay, so this is end diastolic volume increases. So it increases the stroke volume. This is mitral regurgitation. Just memorize these PV loops. Okay, memorize some image. Okay, because he might get these. Other than that, what's this one? During diastole, blood is going from the aorta to the ventricles. What's happening? Aortic regurgitation. Good. So aortic regurgitation, the aortic valve isn't strong there. It's aortic insufficiency. So during systole, everything is fine. The pressure in the ventricles of the aorta is the same. What happens is when the aortic valve closes, it can't close good enough. So blood will trickle back from the aorta to the ventricles. So the end diastolic volume will go up. Okay. Now, what causes diastolic pressure? What is controlling diastolic pressure is a recoil in the aorta. Okay. That recoil against a closed valve, but there's no closed valve in aortic regurgitation. It's insufficient. So the diastolic pressure will be low, very low. This causes a large pulse pressure or a widened pulse pressure, which is a very crucial sign of aortic regurgitation that is important for you guys to remember. Okay, so these two. Remember this end diastolic volume is high because blood from the aorta is going back to the ventricles. This is aortic regurg. How about here? The end diastolic volume is less, meaning there's less blood going to the ventricles. Why would less blood go back to the ventricles? Mitral stenosis. The mitral valve can't open properly. So number one is atrial pressure has to overcome this closed mitral valve. So the left atrial pressure will be very high, as you can see here. And the end diastolic volume will be low. It can't fill as properly anymore because less blood will go to the ventricles. Do you guys understand these PV loops and valve diseases? I'll explain the valve diseases in detail later, but this one. Okay. If it gets you anything, it's a PV loops. It's these figures, okay? Dr. Yaqeen mentioned them and Dr. Santosh. And Dr. Santosh puts a lot of questions in the exam. So please remember that. Now, this one, so we can talk about antiarrhythmics, is you need to just understand the normal physiology in this one. You have two types of action potentials that occur in the heart. You have the pacemaker potential and the myocardial, basically, action potential. This one is a myocardial one, which is the muscles itself. So you have here resting memory potential, the start of the action potential, which is above the threshold, we all know. Then we have phase zero. Phase zero is because of what channel? Sodium. So this causes rapid depolarization. What class of antiarrhythmics inhibit phase zero? Sodium channels. Class 1. Good. Obviously, class 1 has 3 types, and we'll go and talk about them in the next slides. After that, you have phase 1, which is closure of the sodium channels. Then phase 2 is when you have opening of the calcium channels and potassium channels. The calcium channels would move calcium in, potassium will move out. So this causes a plateau, okay? The membrane potential or the potential will not change. Then you'll have closure of the calcium channels and then remaining opening of the potassium channels, which will cause repolarization. Inhibition of phase 3 potassium channels is done by which class of antiarrhythmics? Class 3. Good. Okay, perfect. Inhibits this. Then phase 4, which is predominantly basically done, or the resting membrane potential is by potassium channels. Now, very importantly, I want you guys to remember is there is something else that we can inhibit that can be useful for us in heart failure and some antiarrhythmic and some arrhythmias, which is inhibition of this pump. What is that drug? You guys know. I just want you guys to remember this mechanism. Digoxin. Good. Sodium potassium ATPase blocker. We got this in our OSP. Okay. So remember just this image and this channel. And what drug inhibits this? Okay. So remember digoxin, its mechanism of action. Okay. Inhibits sodium potassium ATPase. Okay. At the level of the heart. Now, over here, you have the pacemaker potential, which is in the SA and AV notes. So phase 4 is basically the membrane potential. However, it's never at a resting. It's always depolarizing. And it's controlled by funny channels, okay? Both class 2 and class 4 can alternate basically this phase 4. Then phase 0, which is controlled by what? The depolarization and pacemaker potential. What ion channel? It's written there, but it's calcium. Then repolarization is done by potassium. Okay. Remember phase 0, phase 3, this channel, and this, because these are the areas that we have antiarrhythmic effects. Okay. Know what these channels are, or what these phases are controlled by. For physiology purposes, if they bring you a physiology question from the normal physiology lectures that you had, it's basically going to ask you what the difference between phase 0 in pacemaker versus myocardium. Okay. Now, antiarrhythmics. Class 1, as you guys mentioned, it inhibits phase 0 by inhibiting or blocking sodium channels. You have different subclasses of class 1 antiarrhythmics, which is class 1A, 1B, 1C. You guys need to know all of these, okay, classes. They all inhibit sodium channels, but the way that they inhibit it is differing by the strength of inhibition. Class 1A, moderately bind to it, okay? What are some drugs? Is quinidine, procainamide, and disopyramidine, or pyramide. Quinidine. What is the side effect of quinidine that you guys need to remember? What is the side effect? Other than widened QRS and QT intervals. Something very specific with quinidine that I want you guys to remember. It can cause thrombosyncronism, okay? Which is headache and tinnitus with quinidine, okay? This is high yield for your exam. Synchronism. For procainamide, it causes one main side effect, which is what? Or one very specific side effect of procainamide. SLE-like syndrome. What other medication I've already mentioned causes SLE-like syndrome? There's two so far. Hydralazine and procainamide. Hydralazine, procainamide. Remember these two drugs. Then you have thrombocytopenia, as you mentioned, yeah, and you have QT prolongation that can cause Trossard's, okay? Remember this image very well. All these images that are on the side, you need to memorize them by heart. So in this case, class 1A antiarrhythmics block sodium channels moderately. So it is the second most potent effect, okay? So you can see from the other class 1C, it's the strongest. It will bring the slope even further back, okay? This one is in the middle. So this is number 1. Number 2 is it kind of blocks some potassium channels in phase 3, so it prolongs the repolarization. Anything affecting phase 3 will cause QT interval prolongation. Remember this. So that can cause Trossard's. Okay? That is basically the effects of class 1A. Class 1B, there's two drugs, lidocaine and then this one. I just want you to remember, lidocaine is a very specific one. And the most important thing to remember about class 1B is firstly, it weakly binds it, and it's the drug of choice for post-MI arrhythmias. Okay? Drug of choice. You need, this one is the best drug to give post-MI. This is the best drug and very high yield to remember. It has no blockage on potassium channels, so it does not cause QT interval prolongation. Okay? That is 1B, lidocaine, which is also an anesthetic. Okay? So that's basically that. Now, class 1C is the strongest binding to sodium channels. Opposite to 1B, this is contraindicated in ischemic tissue. Okay? Contraindicated. So post-MI, you never give this. Why is that so? Is this drug is pro-arrhythmic. When you have, and we'll talk about MI complications, the most acute complication that can happen is sudden death. Okay? Why is that this infarcted tissue is very arrhythmic. Very, very arrhythmic because of sodium. Okay? Sodium accumulation. So when this happens, if you give a drug that is already pro-arrhythmic to a tissue that is pro-arrhythmic, you're going to cause an arrhythmia. So that's why it's contraindicated. Okay? So this is, you have two drugs, flecainide and propafenone. Okay? These two drugs, which is 1C. Okay? So that's basically that. Memorize these effects. 1A has moderate and has slight potassium channel blockage. So it prolongs the repolarization, which will basically prolong the QT interval. 1B has the best effect on post-MI tissue, and it has the weakest effect. So the slope is the weakest. This one, 1C, has the most effect, okay? And is contraindicated in post-MI tissue, okay? Now, class 2 antiarrhythmics are the beta blockers, okay? So we already talked about beta blockers, so we don't really need to talk about them in detail, but basically how does it cause its effect? Is it inhibits beta receptors at the heart, beta-1 receptors. This will basically act on pacemaker cells, okay? And they say an AV node. It decreases the rate and rhythm. How does it affect the rate? Is by phase 4. This is how you control the rate, okay? By phase 4. So it decreases the depolarization slope of phase 4, very long, okay? It also prolongs the repolarization, okay? So it does two effects. Here, it's used in many things, and for side effects, it's what we mentioned already with the antihypertensives. It's the same thing, okay? So let's move on from class 2. Now, one of the medications that we're going to talk about can cause all of these side effects. What is this medication? Amiodarone, excellent. What class is amiodarone? Class 3, excellent. So what can you see in this first image? What is the first side effect that you can see here? Just these two. Pulmonary fibrosis, good. How about this one? What's happening with him? Blue, okay, blue skin, okay. How about here? What's happening in the cornea? Deposits. What other two organs that are commonly affected by amiodarone? Liver, good. Hepatotoxicity, one other organ. We mentioned lung. From thyroid, good. Thyroid, okay. So you need to monitor with LFTs, liver function test, thyroid function test, and what's it called? And thyroid function test, liver function test, and pulmonary function test. Okay, the lungs. As we mentioned, pulmonary fibrosis. So class 3, you have these drugs, amiodarone. I want to remember, amiodarone is the most commonly asked drug from all of these. Okay, you would always get a question on amiodarone because of its side effects. There's so many side effects. Okay, sotalol, diphthylide, and butylide, other drugs that you can give. Sotalol is a beta blocker, has class 2 and class 3 effects. Okay. So here you have the side effects with all of these other drugs, but just remember the amiodarone effects has so many, and cardiovascular effects, as you mentioned in chat. Now, what channels do these drugs block. They're class 3, so inhibits potassium channels, which delays repolarization. When you delay repolarization, class 3, okay, when you phase 3, you inhibit that. What is prolonged in the ECG? I kept mentioning it. QT interval, okay, QT, which can cause torsades, okay? Exactly. Good. Now, the last one is class 4, which is the non-dihydropyridine calcium channel blockers, diltiazem, verapamil. We mentioned the side effects, but it's similar to beta blockers, but it's not as potent. It's not as strong. That's it. Okay, that's all you need to remember for this. Memorize these pictures, these changes in the action potentials. These are very important high-yield images. Okay. Now, other than that, you have other antiarrhythmics. I just want you to remember that adenosine is very important because what arrhythmia can you treat with adenosine? SVT. Good. Now, what is the first step in management in patients with SVT? What can you do for the patient? You can give adenosine, yes, but what other things can help control and restart the heart, basically? Vasovagal reflexes. Okay. You either do a carotid massage or blow on something. Okay. Strain. This resets the SVT. From all the arrhythmias, in terms of management, Leanne told me she covered AFib and VFib and how to manage it. This one is also very important, as you need to remember vasovagal reflex and medication, adenosine. Okay. The other thing about adenosine is its adverse effect, which is a very, very, very like specific side effects, which is the sense of impending doom, chest pain, hypotension. They feel like they're dying. When you give patients adenosine, they literally feel like they're dying. Okay? If you really think about it, adenosine will restart the heart. So they feel this impending sense of doom, bronchospasm, chest pain. Okay? Other than that, magnesium, it's effective in Torsades de Pons, which is another important thing to remember, actually. As you remember, magnesium, the management of choice or drug of choice for Torsades. Okay? That's basically the antiarrhythmics. All right? Now, myocardial infarction. Okay? So MI, similar to peripheral vascular disease, is just in the heart now. Okay? Occlusion of the coronary arteries. Now, it has multiple different presentations depending on the severity of the occlusion. If you have occlusion that's above 70% but below 90%, what is this type of MI, or let's just say ischemia? Stable angina. Stable angina is occlusion of the coronary arteries beyond 70%, but less than 90% occlusion of the lumen. Okay? This is stable angina. If I tell you I have a patient who has pain only on exertion, what type of ischemia do they have? Only with exertion. Stable angina. Excellent. How about pain even with rest? Any of these. Okay? Any of these. Okay? We can tell by other stuff. Which one of these do they have? Okay? These are basically when you have these two is above 90. This one is usually 100% occlusion. Okay? This is when you have ST elevation. Now, troponin levels. Do you see elevation of cardiac enzymes with stable angina? Yes or no? No. How about unstable angina? No. And STEMI? Yes. STEMI? Yes. Now, usually you don't have infarction until you have beyond 90%, usually. Now, if you really think about it, if you have this blood vessel and you have 90% occlusion, will you have infarction that's happening here? Yes or no? No. Will it involve the full thickness? Yes or no? No. So what type of infarction will you see with NSTEMI? Is it transmural? Subendo. Excellent. Good. Subendothelial infarction with NSTEMI. Why? Is because you still have some blood. So majority of the ischemia, or let's just say over here, okay, because it's more realistic when the infarction will happen here. Here you still have blood that is flowing over here. So the tissue over here, subendothelially, will be infarcted. How about the tissue that's going to be in the distal two-thirds? Why will it not be infarcted? Why is it only subendothelial? Is you have blood vessels over here, very small blood vessels over here, that will supply it in this distal area, okay? Proximal subendothelial would be infarcted. How about if you have a STEMI, full occlusion? What type of infarction? Transmural, full thickness. Good. Now, ECG changes. Will you see ECG changes in stable angina? Typically, usually. No. Unstable, maybe. You might see. NSTEMI, yes. What will you see in NSTEMI? You already mentioned it. ST depression usually, and you might see Q waves. How about STEMI? It's in the name, ST elevation. Okay. You guys need to remember these changes. Okay. All right. You need to remember the differences between these different presentations. Very important. Okay. Now, how do you diagnose a patient? A patient is coming to you with chest pain. Okay. And it's commonly the way they describe it is it radiates to the neck or radiates to the shoulder. And you have associated with sweating and these dyspnea, difficulty breathing, and so on. What will you do next for this patient? To diagnose them, what will two things you want to order? ECG and cardiac enzymes. Good. Now we'll talk about cardiac markers. So cardiac markers, you have many, okay? You do need to remember these levels, okay? All of them. Now, from all the cardiac enzymes, which one is the last cardiac marker that will go away? Very last one, last one. LDH, good. It's the last one. It usually lasts 2 weeks elevated, okay? Do you guys know which LDH is usually elevated in MI? Is it LDH1 or LDH2? Usually in the blood, LDH2 will be more than LDH1, usually. In the case of MI, LDH1 will go above LDH2. Okay, just something to remember because biochemistry, they ask random stuff. So anyways, if I give you a scenario that a patient presented to MI, it's been 1 hour, what marker would you want to use? Realistically speaking, I would agree with you. Okay, I would agree myoglobin because it increases very early. Some reason in your slides, and say CKMB is a marker of choice for to detect it in the first hour. Okay. All right. It doesn't really make sense to me, but remember, memorize it because it's in your slides, and if they bring anything, it's from that. Okay. Now, something actually important clinically is if you want to check reinfarction after 72 hours, what marker do you actually want to use? CKMB. Why? Because it goes away after 72 hours. So if you want to check if they have reinfarction, CKMB will be the best. Okay. What is the most specific for cardiac tissue from all of these markers? Troponin. Excellent. Good. That's basically the cardiac enzymes in a nutshell. Remember, memorize these. The first hour one is kind of annoying, not gonna lie, because realistically it should be myoglobin. But maybe because it's not specific and sensitive, maybe that's why you want to use CK. If you can see it elevates higher than everything else from this graph, maybe that's why. Okay, that's cardiac enzymes. Now, what can you see in this image, in these two images? What is your diagnosis? The purpose of the slide is for you to not know how to diagnose based on these images. I want you guys to know when would you use these images. Okay. So what have you mentioned? There is stenosis. So if they have stenosis plus chest pain plus ST elevations, what do they have? MI, myocardial infarction. Okay. What is the modality of choice to visualize coronary arteries? What is it? CT angio. Excellent. That is high yield to remember. What is the modality of choice to visualize cardiac tissue? Tissue. MR. Good. MRI. What is the best to visualize valves, to visualize function as well? Echo. Good. These are the three, ultrasound, echo. Okay. These are the three modalities that you need to remember. Okay. That's pretty much that. Okay. This is why I put this line is remember to visualize coronary arteries, you need to do CT angio. Okay. So this is you will get questions on these. Now, the age of infarction is very important. How old is this infarction in this patient? Just based on this image. Excellent. Less than 24 hours. Give me two features of why you'd say less than 24 hours. One of them is in this side, wavy fibers, and then what's happening with these cells. Yeah, pycnosis and everything. So what's happening? Coagulation necrosis. Okay, coagulative necrosis and wavy fibers. Memorize these images, guys. Like they will ask you. Dr. Broad likes to ask these types of images. Okay, so wavy fibers, number one, and coagulative necrosis. How can you tell it's coagulative necrosis? Number one, it's the structure of the tissue is the same. It does not change shape. That's why we say it's coagulative. Number two is you have signs of dying cells. How? Nuclear pycnosis, karyohexis, and all these terms that we learned in POD back then. Okay, so this is coagulative necrosis. First 24 hours. How about this patient? What happened to them? Reperfusion injury. Good. What can you see here? This is what we call contraction band. Excellent. Contraction band necrosis. Good. The idea of this is your blood vessel. This is where you have the occlusion. This is distal, this is proximal. Everything down here below or distal to the occlusion is not getting blood supply. So what's happening to these dying cells? They're releasing free radicals and everything. So when you have free radicals being released, once you remove the occlusion, okay, all the metabolites such as calcium, very important, the free radicals will go to this healthy tissue and cause necrosis. Okay, this is what we call contraction band necrosis, reperfusion injury. Okay, how old is this infarction? 1 to 3 days. What's the cell that's accumulating in this tissue? What type of cell? Neutrophils. Excellent. Good. That's it. Okay. Dense neutrophilic infiltrate. You can see some neutrophils over here. All right. So yeah, neutrophils. How about this? 3 to 10 days. What cell is accumulating now? Macrophages, and it's basically phagocytosing all the dying neutrophils. Okay. That's basically that. Okay. This says 7 to 10, 3 to 10, both the same. Okay. So macrophage infiltrate, phagocytosis of dead cells. Now, how about this infarction? Up to 2 weeks. Good. And granulation tissue. Excellent. Granulation tissue is basically newly formed blood vessels. You can see the vascularization that's happening and fibrosis. That's slowly occurring, or collagen deposition. That's why it's granulation tissue. Okay. So that is 10 to 14 days. How about this? 2 months. and months. Okay, let's just say that. And what can you see? Blue always means what? Scar, which is collagen, which is fibrosis. Okay. All right, that's it. Okay, there's decreased cellularity. All right. These images, all the images that you just seen, memorize it by heart. Okay. You will, like, if he gets any of them, like, he will get them in either MCQ or in OSCE. Okay. So memorize these. Now, in terms of management of acute coronary syndrome, you have multiple. Okay. So, as I said, in unstable angina and NSTEMI, usually it's 90% occlusion. It's not fully occluded. Okay. So here you can start with antiplatelet, anti-ischemic, or anticoagulant therapy. Okay. However, or you always start with these drugs. There's also other drugs that you want to start with them. And the best way to remember it is remember MONA. Morphine, oxygen, nitrate, aspirin. MONA. Okay. Morphine, oxygen, nitrate, and aspirin. However, with these drugs, there's one drug that I want you to be careful in right ventricular MI. Which one of these drugs? Nitrate. Good. Excellent. This is a very important thing, is you exclude right ventricular infarction. Okay, because then you'll have worsening fluid overload and heart failure and die. Okay, this is important. Other than that, also another one drug that you can give is beta blockers. And I want you to be careful in cases of right coronary artery infarction because it already inhibits SA and AV node. Like the infarction will impede both of these structures. If you give beta blockers, it will decrease the heart rate even more. Okay, so it makes cards fatal bradycardia. So if the patient presents within 90 minutes from the door, you can intervene with PCI, which is percutaneous coronary intervention, or CABG, okay? CABG can present later, but PCI is very easy to do and better for cardiologists to do. CABG is a whole surgery, where you basically, it's coronary artery bypass grafting. You take either a vessel from the leg, the saphenous vein, or the internal memory artery from here, and you basically bypass the occluded coronary artery. Okay, this is a whole surgical procedure. This is interventional cardiology. This is in NSTEMI. You start with these and all the drugs that I mentioned, MONA drugs and oxygen. And then if fit, you do this. Okay. Now for STEMI, you always have to treat some way. Okay, because it's fully occluded. Okay, and the other one, it's not fully occluded. This one is fully occluded. You start with the same management. Same. You first do ECG, cardiac enzymes. You start the patient on antiplatelet, anti-ischemic, or anticoagulant therapy if they don't have contraindications to them. Then you start MONA drugs. You need to check if there's right ventricular involvement or SA and AV node involvement. Then you treat. Okay, you treat either with thrombolytics, as I mentioned which ones before, or if it's within 90 minutes, you do PCI. If not, then you see if they're fit for surgery, you do CABG or not. Okay. This is basically treatment of acute coronary syndrome of MI in a nutshell. Okay. So now, what is this complication that's happened to this patient who had an MI? Number one, you can see that this is a pacemaker, but ignore that. What happened other than that? Not cardiomegaly, not hypertrophy. No. The heart should be till here, right? Why is this bulging part of the heart now? Aneurysm. Okay, excellent, good. This is ventricular aneurysm, all right? This is one of the complications. Which complications do I want you guys to fully memorize by heart? There's three high yield ones that I need you to know. Firstly is, what is the cause of death immediately at an MI? What is the cause of death? Arrhythmia, fatal cardiac arrhythmia. Good. 3 days later, someone had an MI. 3 days later, he's complaining to you of chest pain that improves when leaning forward, pericarditis. How about 2 months later, presenting to you with chest pain, better and improved with leaning forward? What is that? Dressler syndrome. Good. Okay. Dressler syndrome. Perfect. Okay, these are the three main ones that I want you to remember. There are others. I want you to, other than that, just remember papillary muscle rupture can lead to what valve disease? Regurgitation of mitral valve. Good. Mitral regurgitation. Excellent. These are the, you need to remember the timings. So first days to even several months, cardiac arrhythmia. This is the most important cause of death. Most important thing. Post-infarction pericarditis happens because of irritation from the infarcted tissue to the pericardium, direct, okay? Which causes all these things. And I'll mention what pericarditis can present with and everything from that. And then post-cardiac, which is Dressler syndrome, which is because of autoimmune damage to the pericardium, okay? Good. Going to this, what does this patient have? Pericarditis, good. So let's just say a patient presenting to you with chest pain that improves leaning forward. That is important sign number one. If you auscultate on this patient, what could you hear? Or even just try to hear it. Fibrous rub or frictional rub. Good. Or it's a very like, think of a Velcro, okay, for shoes or whatever. Think of that. Okay, that's fine. Now, that's basically that. That's how pericarditis is usually presenting with. There are other subtypes of pericarditis that has other features that we'll talk about. Okay. Now, for pericarditis, if you do an ECG, what can you see here? That's the elevation. Is there something specific about the ST elevation? PR depression is good. Okay. The thing about the ST elevation is diffuse. You cannot localize where the ST elevation is. It's diffuse, multiple leads. This is very important to remember. And you mentioned really good as PR depression. Okay. As you can see. Uh, uh, anyways, so yeah, PR depression. But the most important thing for pericarditis that I want you to remember, and you will get an ECG about it, is ST elevation. Okay, I kind of like that, but anyways. So this is what modality? Best modality for visualizing tissue? MRI. Good. Okay, this is just showing a more hyperintensity in the pericardium. Okay. Now, what are the causes of pericarditis? Just throw me causes. Most commonly, it's idiopathic, but what are other causes? Viral. What viruses can cause pericarditis? Coxsackie. Memorize Coxsackie. Post-MI, you guys mentioned very well, two syndromes, either the first one, which is first 3 days, or Dressler syndrome. Okay, pericarditis. What is a complication? TB, excellent. Okay, what is a complication of kidney failure that can cause pericarditis? Uremia, excellent. Memorize these. Okay, now, how do you manage pericarditis? Very simple. It's usually supportive management, which is basically analgesics. You give them NSAIDs, you give them acetaminophen, and so on. You tell them to stop sports for 3 months, I believe. And there is one medication that's very specific to treat pericarditis. What is that medication that you give for 3 months? Colchicine. Okay, good. Memorize colchicine. If some of these analgesics fail as well, you can give steroids afterwards. Okay. So that's basically the management of pericarditis. Pathology, you need to memorize the pictures. What type of pericarditis is shown here? Fibrinous, perfect, or serofibrinous, okay? Perfect, good. This is what Dr. Abroad loves to mention as bread and butter pericarditis, okay? And most of the time, in the question stem itself, bread and butter will be written. Okay, so as soon as you see that word, you pick this fibrinous or serofibrinous pericarditis. Okay, how about this? Patient has severe fever. Yeah, this is suppurative pericarditis. Good. Has a lot of pus. Okay, suppurative purulent pericarditis. Good. Now, what is this? What's happening to this patient? Tamponade, pericardial effusion. I'll accept both answers. Good. Perfect. Okay. The first sign is the chest X-ray. You can see cardiomegaly. Then in the echo, you can see clearly that there's pericardial effusion or tamponade. Now, there is a specific triad for cardiac tamponade. Do you know what the name of this triad is? Beck's triad. What is the three components of Beck's triad? Hypotension, good. Increased JVP and muffled heart sounds. Okay, not murmur, muffled heart sounds. Why is there muffled heart sound? Because there's space now, so you can't hear the heart sounds as well anymore. Okay, because of the fluid. So it's muffled heart sounds. Another thing is electrical alterans or even pulsus paradoxus. What can you see in pulsus paradoxus or electrical alterans? Unequal pulses and changes in the pressure by 10 millimeters of mercury upon inspiration. Okay, it changes. Okay, this is the alterans. Another thing is you might see, excellent, Cosmo sign, which is this. Okay, elevation of the JVP upon inspiration. Okay, is Cosmo sign. Good. So these are basically what cardiac tamponade is. The cause of cardiac tamponade simply is firstly trauma. Okay. Number two is post-MI. If you have a ventricular aneurysm or rupture, it might seep into pericardial tissue or pericardial space, sorry, and cause cardiac tamponade. Okay. This is a medical emergency because it can cause heart failure immediately and death. How do you manage it? In cardiac tamponade infusion, you need to do pericardiocentesis. Okay, that's it for cardiac tamponade. How about this type of pericarditis? The patient has Cosmo signs of heart failure. This is constrictive pericarditis. We have calcifications. Okay, this causes heart failure, similar to why tamponade causes heart failure, because the heart no longer can pump. It doesn't have space to fully fill up and pump. Okay. Important thing, will you hear any heart sound? I'm sorry, lung, like abnormal lung sounds in either of these two diseases? Yes or no? Will it be clear lung sounds? Answer here is yes. Yes. Why is it there's no involvement of the lungs? Why Dr. Naji loves to pinpoint on this is because in heart failure, you might see similar signs as cardiac tamponade. Okay, the JVP, hypotension maybe or whatever. Okay. How do you know that this is heart failure and or cardiac tamponade and heart failure? In heart failure, the blood will go back to the lungs. So you'll hear crackles in the lungs. In tamponade, this never happens. The blood will not go to the lungs. Lungs are normal. So you'll see clear lungs. The lungs have no pathology in them. Okay, this is an important feature to differentiate the two. Okay. Now let's go for tumors. These two tumors. Which one is often singular in adults and causes syncope? Myxoma, which is B. Excellent. So B happens typically in adults, typically involves which chamber of the heart? Left atrium, excellent. And it basically causes the pinball phenomenon or whatever it was called. where it closes the mitral valve and it causes decrease in the ejection of the heart, and this causes syncope. Okay. This is the characteristic way that it's always described in every exam. Okay. There are chromosomes associated with myxomas. I think it was 15 and 17. But I think so. Or 12 and 17. Memorize these 12 and 17. Excellent. Good. Yeah, 12 and 17. Remember these two chromosomes for myxoma. Now, how about A? What is A? Rhabdo. Good. Now, rhabdosarcoma happens in children or adults? Children. Sorry, rhabdomyoma. Rhabdomyoma happens in what genetic disease? You mentioned the gene. What's the name? Tuberous sclerosis. Excellent. And there's two genes, TSC1 and TSC2. Good. Now, what you can see on histology is spider cells, and this is basically the cardiomyocytes are filled with glycogen. Okay. Memorize these two images. Memorize the tuberous sclerosis TSC1, TSC2 genes. Very important. Memorize chromosome 12 and 17. Okay. Just a fact for you guys for the rest of this year. If you see any genes in Dr. Abdul's slides, memorize them by heart. Okay. Now, long scenario. I'll give you guys the gist of it. 28-year-old man, 3 days history, 3 days of fever, chill, generalized weakness, IV drug user, high temperature, and there's these signs. What does he have? Infective endocarditis. Is this acute or subacute? Acute. Excellent. What organism do you think causes infective endocarditis? Staph aureus. Why? IV drug user. Which valve is associated with Staph aureus endocarditis? Tricuspid, right side. Why is because you're injecting blood, you're injecting the drugs into veins. Veins will go to the right side first, right atrium, then the tricuspid valve, first valve it sees. That's why it's associated with tricuspid valve. Okay. Now, there are these phenomena that happens in infective endocarditis. What is this first painful nodule on the hand? What is it called? Osler nodes. Good. What can you see on this image of the retina? Rough spots. These non-tender nodules in the janeway lesions, and then this one in the finger, but splinter hemorrhage is good. This one, the janeway is embolic or vascular phenomena. The rest is usually in what's it called, immunologic phenomena. This one is vascular embolic phenomena. Okay. Now, for any patients with suspected endocarditis, what is two things that you need to do to confirm your diagnosis? Two things. One of them is written, blood culture, and one other thing is written in this scenario. Echo. Good. I'll explain the criteria to diagnose it, but yes, echo and blood culture. Which blood cultures will you use? Which ones? A. Why do you say A? Other than that? What's very important about A that differentiates it from other ones? Because C is also more than one. What does the color tell you? Simply aerobic and anaerobic. It's written, this is a very long, came in our exam. This one, good. Aerobic and anaerobic. You need two different types of blood cultures, aerobic and anaerobic for different organisms. Okay, you need to do both. Now, how many sets of these do you do? Two or more. Okay, 2 or 3 sets is good. All right, one set is not good. So The criteria to diagnose infective endocarditis is Duke's criteria, okay? So you have major and minor criteria. Major criteria is simple, two things, positive blood culture and evidence of endocardial involvement by echo, okay? Usually echo, or a new valve regurgitation, which is usually mitral, aortic, and then tricuspid if it's an IV drug use, okay? Now for positive blood culture, you have typical microorganisms that cause it. Now, viridans, strep viridans. What population of patients typically have strep viridans endocarditis? Dental. Remember dental. Either had a dental abscess, dental infection, dental procedure, whatever the case, strep viridans. Okay? Good. How about strep gallolyticus? What population? Colon cancer. Excellent. Now, this group of microorganisms are basically the gram-negative microorganisms. That's another thing. And Staph aureus, as you already mentioned, is associated with IV drug users. Okay? So you need evidence of this or persistent blood cultures or single positive blood culture for a Coxiella. Okay? Anyways, then you have the minor, yes, Galolyticus is strep bovis. The name just changed. For minor criteria, you have predisposition, such as either predisposing heart conditions, such as bicuspid aortic valve, already had mitral stenosis, or mitral regurgitation, mitral valve prolapse, or has a mechanical heart valves. These are predisposing heart conditions, or any of the congenital cardiac diseases, or injection drug use. Okay, then fever, then the vascular phenomena, such as, for example, Janeway lesions or any of the other ones, immunologic, such as the ones that we mentioned, and microbiologic evidence, positive blood culture, but it's not meeting any of these or anything else. These are the major and minor criteria. You need how many? Okay, I'll just mention. To diagnose them, you need two major, and that's enough. Or one major and three minor, or five minor to diagnose a patient with infective endocarditis. That's basically that. Now, given all of these, what was the organism that is causing the endocarditis? Staph aureus. Good. Let's start one by one. What is this agar called? Staph aureus is the yellow. That's your hint. This is mannitol salt agar. Okay. Salt makes it differential for staph species, and the mannitol is selective for Staph aureus. Okay. What is this test? Catalase. Is Staph aureus positive or negative? Positive. How about this? Which one is Staph aureus? Coagulase positive or coagulase negative? Positive. Good. And they are gram-positive cocci in clusters. Okay. You guys need to remember these variance factors. They are very high yield. Okay, for CVP. Now, which one is caused by Staph aureus? B. Good. It's more invasive. It's more destructive. A is caused by what typically? Strep viridans, good. This one is acute endocarditis, involves the tricuspid valve, very important. And then A involves any other, most commonly mitral, then aortic. This is the mitral valve, and you can see the vegetations on the mitral valve. This one is more invasive, okay? That is basically that. Now for valve vegetations, we already mentioned this one is the vegetations for infective endocarditis. It's more destructive. Rheumatic heart disease, it's verruca that basically is on the valves. Then Liebman-Sachs endocarditis is associated with what disease? SLE. Excellent. Good. This is very high yield comment, remember. SLE patients, rash, think of rash, joints, endocarditis, and Liebman-Sachs endocarditis. Another important thing is involves both sides of the valve. Okay? That's another thing that's very important. How about NBTE? This is called non-bacterial thrombotic endocarditis. Okay, it's associated with what? Adenocarcinoma. Perfect. Okay. And hypercoagulable state. Excellent. That's basically that. Now, this patient has diarrhea, flushing, and bronchospasms. And they have this seen on image. What is this? Carcinoid. Good. Carcinoid tumor or syndrome? Syndrome. Carcinoid tumor is basically where it's a tumor that causes the carcinoid syndrome. This is a tumor that usually involves the lungs or the GI that metastasizes to the liver. Basically, carcinoid tumor is a tumor that synthesizes what hormone? Serotonin. Perfect. This serotonin, if it's in the GI alone, it will go to the liver, gets metabolized and broken down. So this carcinoid tumor will not cause carcinoid syndrome. If it goes to the liver, the tumor itself metastasizes to the liver, then it can cause carcinoid syndrome because the serotonin can bypass the metabolism in the liver. Okay. Another place is the lungs. The lungs has the enzyme, which is monoamine oxidase, MAL, that can break down serotonin. Okay. So now, why is the heart involved? If this carcinoid tumor in the liver, for example, or in the heart, in the lungs, produces serotonin, it goes to the heart from the right side. It involves the tricuspid, causing tricuspid regurgitation, and the pulmonic valve, causing pulmonic stenosis. Okay? This is because of serotonin. The left side cannot be involved. Why? Because the serotonin will go to the lungs, gets metabolized by MAL, and then pass. It can't do its effect on the left side. That's why it's always on the right side. This is carcinoid syndrome because it's causing the right-sided heart disease. Okay, and you can see the thickening in the endocardium. Okay, now there is one urine lab investigation that you can do to diagnose these patients. What is that lab investigation or lab marker? 5-HIAA, good. 5-HT, good. 5-HIAA. What it stands for is I always forget. Let's remember 5-HIAA, okay? So carcinoid heart disease, and it's basically what I mentioned to you guys. Now, what is seen in image A? Calcification. Which valve? Aortic stenosis, good. This is the most common cause of aortic stenosis, which is something that we call wear and tear, basically stenosis, okay? This happens over time. There's calcifications of the aortic valve. A more important thing to remember is it does not basically involve the commissure of the valve, okay, which is basically these. It does not involve it. It only involves the cusps. This is important for other diseases that has this involvement, okay? Now, B shows you what? It's an aortic valve. Yes, congenital bicuspid aortic valve. Good. Now, congenital bicuspid aortic valve, they will have stenosis earlier than normal aortic valves, okay? Just a little earlier, okay? So that's important about bicuspid valve. How about this patient? What do they have? I'll give you a hint. This patient also has Marfan syndrome. Mitral valve prolapse, excellent. So you see ballooning of the valve, okay? This is commonly seen in patients who have, again, as I said, Marfan syndrome, okay? Now, what is seen on histologically? Myxomatous degeneration of the valve. Excellent. Good. Memorize this description. Myxomatous degeneration of the valve, mitral valve prolapse, and is commonly seen with Marfan syndrome. Okay. And typically will then later cause mitral regurgitation. All right. So that's mitral valve prolapse. Now, I have a patient who had pharyngitis 2 weeks later, presents with myocarditis. What does this patient have? Firstly, tell me, what does this patient have? I had pharyngitis, didn't treat it. 4 weeks later, presented to you with myocarditis. Rheumatic heart disease, excellent. Good. What other features can you see in rheumatic heart disease? Just remember Jones criteria. Joints, so arthritis, pancarditis, subcutaneous nodules, erythema, and then migratory erythema, and then last one is the Sydenham chorea. Okay, this is what you can see, and it's caused by what organism? What organism causes? Strep pyogenes. Okay, good. What virulence factor of strep pyogenes causes rheumatic heart disease? Streptolysin OCAM. It's a very specific M protein. Yes, that's the one. Okay, because it's similar to the myocardial tissue. Okay. Anyways, you do histologic appearance. What is seen in this first image? Aschoff bodies. Good. And then what are these cells? Anish-Cow cells. Good. This is described as caterpillar nucleus. Okay. This is an Aschoff body which has macrophages, which are all these Anish-Cow cells. Okay. These are macrophages. Good. Rheumatic heart disease. Now, this is a valve that's seen in rheumatic heart disease, which is verruca. As I mentioned, it's just linear on the valve from the figure before. So it's linear onto the valve, okay? Now, chronically can cause these things. What is seen in these images? Mitral stenosis is this one, excellent. Because of what condition that causes mitral stenosis? Fish mouth, excellent, good fish mouth appearance. And it's because of chronic rheumatic heart disease, excellent. Now, how about over here? What valve is involved? Aortic. Why is this not wear and tear calcific aortic stenosis? Fusion of the commissure, okay? This, excellent, good, okay? In wear and tear calcific, the commissures are not fused. In rheumatic heart disease, it is, okay? That's how you can tell the difference. And this image is high yield. And if he asks you anything about to tell the difference between calcific and rheumatic, it's these two images, this and the calcific one. Remember the commissures, okay? Now, very quickly onto the valvular heart diseases, like the basically signs and symptoms of each one. I will go quickly onto these so we can save time and tell you guys which ones to like look out for. Firstly, aortic stenosis, we mentioned all of this. Now, what type of murmur does it cause? It's systolic crescendo decrescendo, okay? Systolic crescendo decrescendo. Where can you hear aortic stenosis? Which area? Where is the aortic area? Remember the Pal Bites video, please. No, that's the tricuspid. And it's if it's next to the sternum. Right second intercostal sphincter. Good. Okay. Good. So this causes crescendo decrescendo, and I mentioned all of this. Okay. So mitral and tricuspid regurgitation usually happens in acute rheumatic fever or rheumatic heart disease. It happens, or mitral valve prolapse, or here because of what's it called? As I mentioned, the Marfan syndrome. Okay. Now for mitral tricuspid, it causes systolic, hollow systolic, all throughout systolic, blowing murmur. Okay. Now where can you listen mitral valve in the fifth or fifth intercostal space at the mid-clavicular line? Tricuspid is left side next to the stern. Okay. On the fourth intercostal space usually. Okay. That is the tricuspid regurgitation point. Prolapse has a mid-systolic click. VSD, I'll explain in the congenital cardiac like quickly later on. Aortic regurgitation, again, happens typically with rheumatic fever or aortic root dilation, which happens in aortic dissection, okay? And then you have endocarditis that can cause it, bicuspid aortic valve, okay? Importantly, I already mentioned, widened pulse pressure. The systolic is going to be high, diastolic will be low. So you'll have the widened pulse pressure. You'll have pulsatile nail beds. So you can see like the nail bed itself is very pulsatile, and you can see a pistol shot, which happens either femoral or even basically they'll be bobbing their head, okay, because of the high pressure. So that's aortic regurgitation. Um, Then you have mitral stenosis, which happens chronically because of rheumatic heart disease or anything else. That's usually rheumatic fever. And then you have a diastolic opening snap. Okay. Now, PDA, congenital heart disease, we'll mention it later. So now for myocarditis. Okay. Myocarditis, similar to pericarditis in terms of what can cause it. Could be idiopathic and could be infectious, could be other things. Infectious, what virus can cause myocarditis? It's the same as pericarditis. So what? Coxsackie. Remember Coxsackie, this entire block, okay? So Coxsackie virus. You have multiple forms of myocarditis. So this one is most likely the form that is from Coxsackie. You have lymphocytic infiltrates. Here, it's most likely going to be allergic or something with hypersensitivity myocarditis. Why? Because you see eosinophils, okay? C is, you see these cells, which are what cells? Giant cells. So this is called giant cell myocarditis. And how about D? What is seen in D? Chagas disease. What is the organism? Trypanosoma cruzi. Okay, good. It's a parasite. Perfect. So this is basically the forms of myocarditis. Okay. Now, myocarditis can cause this. What is this disease? Dilated cardiomyopathy. Good. So dilated cardiomyopathy can have a genetic predisposition and environmental. Environmental such as alcohol, postpartum or peripartum cardiomyopathy, myocarditis can cause it, hyperthyroidism, hypothyroidism. There's a lot of environmental causes, and as well as genetic. Now, for genetic, I want you guys to remember what are the genes that are involved. What is the main muscle component genetically that is involved in dilated cardiomyopathy? This is very extremely high yield. As I mentioned, any form of genetics or what marker for Dr. Abrar you have to memorize. Dystrophin is one. What's another one? The most important one for dilated. Titin, okay? Or titin, how you pronounce it, okay? These two, dystrophin, and more importantly, titin, okay? These two are important for dilated cardiomyopathy. Now, what can you see? What is this appearance? What can we call this nucleus? Ninja star. Good. Now, the issue with dilated cardiomyopathy is you have failure of diastolic or diastole or systolic. What type of heart failure can develop? Systolic or diastolic? Systolic. Good. Why? It's because diastolic is, how do you determine diastole? Is by filling. It can fill more than properly. The compliance is good. However, the heart muscle is weak. It's thin. So this is diastolic. It can cause diastolic heart failure. Okay? So this is dilated cardiomyopathy. How about this disease? Okay, right ventricle. What about it? Arrhythmogenic right ventricle. Okay. Right ventricular tachycardia, whatever it was called. I think that's what it was called. I just see cardiomyopathy, sorry. Arrhythmogenic right ventricular cardiomyopathy. Now, what happens here is you have replacement of the myocytes with fat and fibrous tissue. So the myocytes in the right ventricle is very thin and weak. Look at the left ventricle, it's good. Right ventricle. Now, this has a genetic predisposition and it has a specific mode of inheritance. What is the mode of inheritance for this disease? This is an autosomal dominant disease. Good. Okay, so this is arrhythmogenic right ventricular cardiomyopathy. How about this patient? What do they have? I'm not sure if there's a gene involved with that other one. This one, yes. Just remember it's autosomal dominant for the arrhythmogenic. This one has, and it's important. Hypertrophic cardiomyopathy. Good. Okay, cool. It's basically where you have haphazard myocytes, which is basically how to describe this. And typically, it's irregular. It's asymmetric hypertrophy, which is basically has a septal predominance. Now, this is usually, if you ever get a scenario of an athlete, okay, that suddenly collapse in a field, it's most likely that they have this, okay, hypertrophic cardiomyopathy. Because of the cardiomyopathy, because of the hypertrophy, arrhythmias can occur, usually VFib, okay, very severe arrhythmias. So these patients collapse and die. And usually they have a family history of a father, an uncle, or something that had a heart disease and died at a very early age, okay, like 40s, okay? So that's basically hypertrophic cardiomyopathy. It's usually genetic, okay? You can get hypertrophic heart, not cardiomyopathy, so heart hypertrophy, when you have, for example, hypertension or aortic stenosis because of the increased afterload. Cardiomyopathy, genetic, okay? What genes are associated with hypertrophic cardiomyopathy? Two parts of the muscle. It's involved in sarcomeric proteins, two of them. Myosin binding protein C, excellent, and myosin light chain, okay? These two, mostly these two, okay? That's hypertrophic cardiomyopathy for you. Now, you have one other form of cardiomyopathy, which is restrictive. Restrictive happens due to other causes. One of them is this. What is this disease? Amyloidosis, perfect, which is all this amorphous pink material that's depositing between the myocytes. What is this dye first called? Dye and then the sign. Congo red, and what can you see on Congo red staining? Apple green bifringence, okay, which is light, okay, which is all this green light, okay? This is amyloidosis, as you guys mentioned. Other causes of restrictive cardiomyopathy could be radiation. So someone had cancer and received radiation treatment, or sarcoidosis. Okay, so that's basically the cardiomyopathies for you. Now, these basically just show you myocarditis and amyloidosis. I don't expect you, again, to tell me that this is myocarditis or amyloidosis. This is extremely beyond the level. But as I mentioned before, if you want to localize or visualize myocardial tissue, you do an MRI. Okay? That's the point of this, all right? You have to do an MRI to visualize myocardial tissue. That's it. Now, for heart failure, you have it's important for heart failure to recognize the signs and symptoms and differentiate the types. I'm going to go old school and basically tell you left and right heart failure to make it easy. Okay, let's start with left heart failure. If you have left heart failure, what signs and symptoms will you have? Left heart failure. Pulmonary congestion, which will cause what? Dyspnea. What about dyspnea? You need to tell me exactly what in dyspnea. Paroxysmal nocturnal dyspnea, and one other dyspnea related, orthopnea. Good. Paroxysmal nocturnal dyspnea is basically the patient will wake up, okay, in sleep because they have shortness of breath, okay? Other thing is orthopnea, which is what? I mean, just one thing that the patient will do to fix orthopnea. Sleeping, supine. What will typically in scenarios, what will they do, these patients with orthopnea? Sit up or sleep with multiple pillows, okay, to be elevated. That is one major way they describe it to you guys in questions. Okay, pillows, multiple pillows. Okay, this is science. This is orthopnea. Other than that, is you have congestion, basically, and pulmonary edema. Okay, as you guys mentioned perfectly. Now, left heart failure can cause what as a complication? Because of pulmonary edema. Right heart failure. The most common cause of right heart failure is left heart failure. Okay. What if you have isolated pulmonary disease that causes right heart failure? What is this called? A pulmonary disease that causes right heart. Excellent. Cor pulmonale. The most common pulmonary disease to cause it, there's many. You have, for example, COPD, interstitial lung diseases, and very commonly is pulmonary hypertension. Okay. So that's that. And I'll get to all of these diseases inshallah in the pulmonary crash course. Um, Now, in terms of right heart failure, what are the signs and symptoms? Edema, peripheral edema, and increased JVP and decreased tissue perfusion typically. And you have congestive hepatomegaly, which you'll see the nutmeg liver, okay, in it. And now, clinically, we don't describe it as left heart and right heart failure or systolic diastolic. We characterize it as HFpEF or what's it called? HFrEF. HFrEF is heart failure with reduced ejection fracture. HFpEF is preserved ejection fracture. Okay, ejection fraction. So these are the two types. Reduced ejection fraction is typically what we used to describe it as diastolic heart failure. Okay, where the heart is not contracting as much, but the compliance is very good. Okay, horrible though. Preserved ejection fraction is the heart is contracting really good. However, the compliance is nothing. Okay, so this is the two types. And you guys mentioned everything about the features that you want to remember. Okay. Now, other than that, we go to management of heart failure, which is very important. Okay. Now, in heart failure, you want to do a couple of things. Number one is you want to reduce the load into the heart. Okay. Reduce the load of the heart. You can do it in two ways. Number one is you decrease the sympathetic outflow onto the heart. Okay. Onto the heart. All right. So you decrease heart rate and you decrease contractility of the heart. What medication can do this? Beta blockers. Excellent. Good. Another thing is you decrease sympathetic outflow. Okay. Again, beta blockers can do some of that. Another thing is you inhibit the whole RAS pathway, which is with what medications? Or decrease vascular resistance, sorry. ACE inhibitor, ARBs. Okay. That's number one. Okay. Number two is you want to reduce cardiac remodeling. Okay. Which medications can you give to reduce cardiac remodeling? ACE inhibitors, excellent. Other drug, potassium sparing diuretics, and excellent ARNI, which is ARB plus neprilysin inhibitor. What is a neprilysin inhibitor? What is the drug called? The neprilysin inhibitor is called sacubitril. Okay, good. So you give valsartan with sacubitril. This is the drug of choice usually. Always, like a lot of patients get this drug, okay? So that's another mechanism to reduce heart failure. The other mechanism is in heart failure, you have edema everywhere because of volume overload. So what can you do to counter volume overload? Diuretics, okay? In acute heart failure, acute decompensated heart failure, the drug of choice is loop diuretics. Another class of drugs is SGLT2, which is a very good drug. The name of these drugs, just remember it's SGLT2. Another name for it is, or the actual name of this drug is called empagliflozin. These drugs, SGLT2 inhibitors, basically inhibits the sodium glucose transporter in the proximal tubule of the kidney. This is one of the main way we can treat diabetes, okay? But it's very good in heart failure, okay? These are basically the drugs. And you guys already mentioned all of them, mashallah. So that's these. Now, in specific populations, when would you give, or actually, for African Americans, what drug can you give? Very specific. Diuretics and calcium channel blockers are good. That's not actually, because calcium channel blockers, you don't give it for heart failure. This is in hypertension. Good you reminded me. Diuretics and calcium channel blockers are very good for hypertension, for African American hypertension. Hydralazine and nitrates, excellent, good. So hydralazine nitrates for heart failure in African American patients. Good. Okay. That's basically all of these drugs in a nutshell. Okay. Now, what is seen in this image? Very simple. This patient has heart failure. What can you see? Just a sign that you see. Yes, you can see cardiomegaly. Okay, good. Now, what does this patient have? Pulmonary edema. Good. What features of pulmonary edema can you see? Okay. So, very important characteristics. Okay, reticular nodal pattern. Good. But very specific sign of heart failure that you can see on chest X-ray. These linear lines. You can see a line over here. Okay, a line over here, a line over here. This is what we call curly B lines. Okay. Other findings: cardiomegaly, obviously more in the previous image. These curly B lines, reticular nodular interstitial markings, which are all over this, all of these things. Okay, and moderate pleural effusion in this patient. However, it can be very severe. Okay, pleural effusion. Okay, the costophrenic margin or angle will be gone if it'll just be white for pleural effusion. Okay, these are the signs that you see on X-ray for patients with heart failure. Again, this is a very important image for your exam. Now, the final topic before we end this is congenital heart diseases. I will just pinpoint certain things to remember for them because there's a bunch. Okay, and it's just one lecture. Firstly, what is the most common congenital heart disease? Ventricular septal defect. Excellent. Good. It's usually ventricular septal defect, atrial septal defect, and then PTA. This is the order typically. Now, or sorry, VSD, then PTA, then ASD. Then another thing is what's worse, a right to left shunt or a left to right shunt? Right to left, because deoxygenated blood will go to the left side. Good. Now, for the right to left shunts, there's 5. First one is persistent truncus arteriosus. Basically, the aorta and pulmonary artery or pulmonary trunk will divide. It has to divide. If it doesn't divide and remains, it just is one big vessel. So it carries deoxygenated blood all throughout the body. That's basically that. D, transposition of the great vessels. The aorta will come from the right ventricle. The pulmonary trunk will come from the left ventricle. Okay, so deoxygenated blood will go to the system. You need to have some sort of shunt in the heart to be able to fix this. Important thing to remember, I believe, is yes, the egg on a string appearance. Just remember this sign of detransposition. Okay, so yeah, that's that. Then you have tricuspid atresia, which is basically, if you look at this image, this is not tricuspid atresia, but basically this, the tricuspid valve will not be there. Okay, this is atresia. Okay, when this happens, think about it. Can blood go to the right ventricle at all in this case? No, it cannot. So it stays there. You'll have hypoplastic, which is basically small right ventricle, and these patients will have to have a shunt. You need to have somewhat of a shunt, for example, ASD, to be able to survive. Okay, so that's basically tricuspid atresia. Tetralogy of Fallot is the most important one from all of these right to left shunt ones, and it's 4 things: the pulmonary and fundibular stenosis, okay, right ventricular hypertrophy, overriding aorta, and VSD. From all of these, the thing that actually causes the most symptoms is the pulmonary stenosis, okay? This is the most important part of VSD. There's one critical sign of tetralogy of Fallot, I said VSD, tetralogy of Fallot, which is something called TET spells. If the baby, for example, starts crying, has fever, they sneezes, coughs, this causes them to turn cyanotic, okay, in episodes of stress. So what they do in the TET spells is they squat, okay? And when they squat and basically sit down on the floor, this causes an increase in afterload, which will decrease the stenosis of the pulmonary fundibular stenosis, and decreases the outflow obstruction, okay? That's basically the most important thing to remember about this, okay? Other than that, you have total anomalous pulmonary venous return, which is basically the pulmonary veins, instead of going to the left side of the heart, it goes to the right side. So deoxyribotrite cannot go to the left side. And Epstein's anomaly is where basically the right ventricle turns into the right atrium. It becomes very small. Okay, this is Epstein's anomaly. This is the most common thing to remember is lithium. Okay, that's it. VSD, as I said, the most common thing, it's a left to right shunt. Okay. And another thing to remember is its association, for example, with Down syndrome. Okay. Atrial septal defect is another one. Again, very similar. Don't worry too much about all of this. PDA is another important one. It usually closes. However, if it remains open, there will be always continuous shunting from the pulmonary artery to the aorta. Okay, that's it. So you close it. And you close it usually with medications such as NSAIDs, indomethacin. Okay. Now, if these shunts do not close early on, it can slowly reverse. When it reverses, it's something called Eisenmenger syndrome, okay, which is this, which is a left to right shunt that turns into a right to left shunt, okay? That's basically everything you need to know for congenital heart diseases. You can read these two summaries that summarizes basically the entire, whatever, how many slide lecture that you had. And this is basically that, okay? Other than that, I'm done. Thank you guys very much for attending. You guys have any questions? Anything unclear you want me to go over again? Anytime. Inshallah, this was helpful. Anytime. Inshallah, we'll have the pulmonary crash course later on before your exam, inshallah. But anyways, thank you guys so much and have a great rest of your weekend.